وإذا قيل انشزوا فانشزوا يرفع الله الذين آمنوا منكم والذين أوتوا العلم درجات والله بما تعملون خبير. يا أيها الذين آمنوا إذا نجيتم وقدموا بين يدي نجواكم صدقة ذلك خير لكم وأطهر فإن لم تجدوا فإن الله غفور رحيم. صدق الله العلي العظيم. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Memasuki acara selanjutnya, menyanyikan lagu Indonesia Raya dilanjutkan Mars Muhammadiyah. Hadirin dipersilakan untuk menempatkan diri masing-masing.
Selamat datang di Institut Teknologi Kesehatan dan Sains Muhammadiyah Sidrap. ITKES Muhammadiyah Sidrap dilengkapi dengan sarana dan fasilitas kampus seperti laboratorium kesehatan terpadu yang modern, lengkap, dan terintegrasi. Perpustakaan yang lengkap yang dapat diakses secara online maupun offline. Ruang perkuliahan yang nyaman dengan akses layanan internet. Laboratorium CBT terakreditasi dan lokus ujian kompetensi nasional. Dalam menunjang proses pengembangan Al-Islam dan Kemuhammadian terdapat musala dan masjid pencerah. Terdapat auditorium Iqra dengan fasilitas videotron dan audio lengkap. ITKES Muhammadiyah Sidrap memiliki visi menjadi perguruan tinggi yang islami unggul, inovatif, dan berdaya saing global tahun 2029. ITKES Muhammadiyah Sidrap telah terakreditasi baik sekali oleh Badan Akreditasi Nasional Perguruan Tinggi dan memiliki 3 fakultas. Yang pertama adalah Fakultas Keperawatan dan Kebidanan yang terdiri dari 5 program studi yang telah terakreditasi LAMPTKES. Terdiri dari program studi S1 Keperawatan Profesi Nurse, S1 Kebidanan, Pendidikan Profesi Bidan, dan Sarjana Terapan Keperawatan Anestesiologi. Dalam meningkatkan keterampilan klinis mahasiswa, terdapat laboratorium yang lengkap dan terintegrasi. Selanjutnya, Fakultas Farmasi terdapat 2 program studi yang telah terakreditasi oleh LAMPTKES, yaitu D3 Farmasi dan S1 Farmasi. Dilengkapi juga dengan laboratorium yang lengkap yang menjadi wahana praktikum mahasiswa, baik mahasiswa D3 Farmasi maupun mahasiswa S1 Farmasi. Fakultas Teknologi Kesehatan dan Sains terdiri dari 3 program studi yang telah terakreditasi oleh LAMPTKES. Yang pertama, D3 Kesehatan Gigi, Sarjana Terapi Gigi, dan S1 Administrasi Kesehatan. Praktek mahasiswa juga dilaksanakan di laboratorium terpadu ITKES Muhammadiyah Sidrap yang nyaman dan lengkap. Peluang kerja lulusan terbukti sebagai tenaga kesehatan yang unggul dan berdaya saing nasional dan internasional. Ayo bergabung bersama kami di ITKES Muhammadiyah Sidrap. Syarat dan alur pendaftaran sebagai berikut.
academic community for the trust and participation in organizing this information event. We believe that its collaboration rests an excellent step toward strengthening the competitive global competitive of Indonesian healthcare workforces. Terima kasih Pak Rektor ya, yang kita sudah bekerja sama selama 3 kali Pak Rektor. To exclude participants, this webinar is more than is an academic forum for sharing international knowledge, sharing fitness and best practice. It is also reflect our shared commitment, the development competent, innovative, and professional healthcare work who are capable for deliver high quality, cultural responsive, and sustainable healthcare service factors for rural communities. As part of our commitment of quality assurance in healthcare education training, this webinar is conducted toward the mystery of health learning management system platform all speaker participation and resident sehat accounts. Enable integrate learning process, education assessment, a learning education, and community record in accord with the standard establishing the Ministry of Health of the Republic Indonesia. Performance certificate for both speaker and participant will be issued through the official Ministry of Health system and electronically signed by the Director of Healthcare Workforce Quality Ministry of Health of the Republic Indonesia. Assuring official recruitment requisition as part of quasing professional development for healthcare professional. We accord our participation to actually equipment of talk the webinar action and the with a fellow professional and expert expand international network and again available accessible the can be transit into innovation healthcare participate. Together, let's us accountable to important nursing and midwifery service that are culturally responsive, evidence-based, sustainable, and educative, and accept global healthcare equity. Finally, I would like to express my sign credit to excellent civil or academy partners, organize, committee member, and every partisan your equal support and participation. By his in collaboration continue to grow stronger, fostering innovation, excellence, and methodology contribution to healthcare service in Indonesia and access the global community. Thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Bu Halipah atas sambutan pembukaan di pagi hari ini untuk acara Kes, kami persilakan. Selamat pagi, Dokter Muhammad Tahir.
Pagi. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Alhamdulillahi rabbil alamin. Salatu wassalamu ala asrafil anbiya wal mursalin wa ala alihi wa sahbihi ajma'in, amma ba'd. Raditu billahi rabba wa bislami dina wa bi Muhammadin nabiyya wa rasulah. Distinguished speakers on air, guests, respected colleagues, ladies and gentlemen, it is my great pleasure and honor to warmly welcome all of you to this international webinar. First and foremost, I would like to extend my sincerest appreciation and warmth welcome to our distinguished international speakers. Welcome Professor Farida Mohsaid from Lincoln University College, Malaysia. Welcome Dr. Marina Magnolia from Centro Escolar University, Manila, Philippines. We are also on air to help your engagement Indonesia speakers, Nurse Zulkifli Nurdin, Eskap, MM Magister Keperawatan, and Bidan Nurjana, SST Magister Kebidanan. I would also like to extend my respectful greetings to the Directory of PT Hanacaraka Training Center, the Dean of the Faculty of Nursing and Midwifery, or respective lecturers and participation who I joined to international webinar from various countries. On behalf of the rector and this enters academic community of this Institute of Technology and Science Muhammadiyah Sidrap, I would like to express or display greeting to all distinguished speakers from generously sharing your knowledge, experiences, and valuable inspiration with us. We are will delighting be the remembered and who signs to democration by all participants who I join us this virtual platform. We sincerely hope that this international webinar transforming rural community nursing and midwifery innovative, collaboratively responsive in sustainable global health equity will from fight meaningful insight, bread and speak perspective in inspires innovation the participant and implement with the respective country and formal setting. We will have the track international collaboration and academic exchange. We can collective tribal straight getting nursing and midwifery service, particularly in rural community, while advance global health equity. Kami juga ingin menyampaikan apresiasi yang tulus kepada PT Hanacaraka Training Center atas kerjasama yang berharga dan kemitraan yang berkelanjutan. Kami berharap kerjasama ini akan semakin kuat dan menciptakan peluang yang lebih besar bagi kolaborasi akademik maupun profesional di masa yang akan datang. Tentu continue to grow strong and create if greater opportunity player academic and from school collaboration. Finally, I will like to extend my sincere thanks to speakers, participants, organizer, and sporting institute from came this international webinar possible. My today in France successful from meaningful discussions, international participation, and generate lasting benefit and our institution, our community, and defensemen of global health care. May all of your cliff effort become source and community goals and lasting contribution to humanity. Thank you very much from attention. Nasrun minallah wa fatum karim wa basiril mu'minin. Assalamualaikum warahmatullahi wabarakatuh.
Dia
Atas sambutan dan
lo pilihan namun
acara webinar pada pagi hari ini. Terima kasih para hadirin semua. Ini berjalan dengan lancar dan memberikan manfaat bagi kita semua. Untuk acara selanjutnya kami serahkan kepada moderator. Selamat pagi Ibu Tris.
Selamat pagi, Mbak Anggi.
Baik, sebelumnya mohon izin kami perkenalkan beliau Ibu Tri Sumarsi merupakan dosen tetap di Universitas Muhammadiyah Gombong. Baik, kepada Ibu Tri Sumarsi, waktu dan tempat kami persilakan.
Thank you, Miss Anggi. Suara saya aman ya, Mbak Anggi?
Iya Ibu, aman Ibu.
Baik, mohon izin. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen.
morning, man.
Thank you. How are you
Morning.
today?
We are good, man.
Alhamdulillah. I hope you always be given health and happiness. Yeah. All right. Permit me to go first for greeting the Honorable to Director of ITKes Muhammadiyah Sidrap, Dr. Muhammad Tahir, SKM Menkes, the Director of Prima Medicina Hanacaraka, Ibu Halipah, Sarjana Keperawatan Nurse, Magister Hukum Pesqua, the Vice Rectors of ITKes Muhammadiyah Sidrap, the Dean of the Faculty of Nursing and Midwifery, ITKes Muhammadiyah Sidrap, Ibu Nurse Miriam Maisaro, Sarjana Keperawatan Magister Kesehatan, all the lecturers of ITKes Muhammadiyah Sidrap, all the speakers, especially for all the speakers from Malaysia and Philippines, and of course to all of our wonderful webinar participants. First of all, welcome to the session of International Webinar 2026 with the topic Transforming Rural Community Nursing and Midwifery, Innovative, Culturally Responsive, and Sustainable Care for Global Health Equity. My name is Tri Sumarsi. You can call me Ibu Tris. I'm going to be a moderator today. I hope that you will always be given health and happiness. Thank you for joining us to take part in this extraordinary webinar. Before we continue to the main part of the webinar, I will first greet all the webinar participants or audience here, both those joining us by Zoom and those attending in person at the ITKS Muhammadiyah Sidrap. When I mention you, please say hi. We are very happy to meet you all. I started with the participant in the Zoom meeting. Hello, can you hear me?
Yes, clear.
Yeah, my voice is clear, right?
Yes, clear.
Yeah, I will say hello for the participant in ITKS Muhammadiyah Sidrap by offline. Hello?
Not race online.
Oh,
Participant is online, Miss. Yeah.
okay, sorry. Yeah, which one from midwifery study program? Is there any student from midwifery?
Midwifery and nursing.
Oh, can I understand? And perhaps from the hospital or any from other health services? Puskesmas?
Hospital and puskesmas and clinic.
Oh, okay, Alhamdulillah. Yeah. And is there any participants from Malaysia and Philippines who join this webinar? Or all the audience from Indonesia, except the narasumber or speakers? Yeah, great and very good. Thank you so much. May I give you a little poem or pantun before we start the webinar today? Boleh ya saya kasih pantun, Bapak Ibu, teman-teman semua biar kita lebih semangat. And you can say mantap gitu ya. Nanti kalau
Yes.
ya. Pergi ke Malaysia dan Filipina.
Mantap.
Tidak lupa ajak keluarga.
Mantap.
Selamat kawan. Ya, selamat datang kawan semua.
Mantap.
Mari kita mulai webinar dengan bahagia. Please smile by yourself.
Nice.
Karena
Nice smile.
ya. Thank you. Dan bersedekah sedekah yang paling bisa kita lakukan very much. Alright, ITKS Muhammadiyah Sidrap as one of the university in Indonesia wants to give a positive contribution through this webinar related to the topic is intended to transform and enhance rural community nursing and midwifery care in order to achieve global health equity. We have 4 speakers who are already with us. The first speaker is Professor Dr. Faridah Muhammad Said from Lincoln University College Malaysia. Hello, Prof.
Halo, Assalamualaikum warahmatullahi wabarakatuh.
Nice to see you, Prof.
Yeah, happy
Welcome.
to see everybody. Thank you.
Welcome. And the second speaker is Dr. Marina Magnolia from Centro Escolar University Manila, Philippines. Hello, Doctor. Good morning.
Hello, can you hear me?
our first speaker, Professor Dr. Faridah Muhammad Said, with the topic Digital Innovation in Rural Nursing and Midwifery Care, Strengthening Community Health Equity. And before she's going to give the material, allow me to introduce her curriculum vitae. Our distinguished speaker is Professor Dr. Faridah Muhammad Said. She holds a PhD in Community Education and Development from University Putra Malaysia and a master degree in Community Health from University Kebangsaan Malaysia. With an extensive background in nursing, midwifery, and public health. She currently serves at Lincoln University College, overseeing postgraduate PhD nursing studies. She has vast expertise in research methodology, family health, and clinical nursing leadership. Okay, Prof, you have 30 minutes to talk from 99. Sekarang udah jam 10 ya?
Jam 10 ya?
10 to 10:30, Prof.
Yeah.
Then the discussion session for 15 minutes. Okay, welcome to Prof. Dr. Faridah Muhammad Said. Now time is yours.
Okay, can I be my host? Can I present my slide? Can I be the host so that I can share my slide?
Untuk slide-nya dari siapa Mbak Nabila?
Sebentar Bu, kami share screen.
Ya, wait a minute, Prof.
Okay, no problem. Okay, while waiting, Assalamualaikum warahmatullahi wabarakatuh. Dan bagi pihak saya, please allow me to speak in bahasa Malaysia. Kita serumpun ya. So maybe some of those part I will speak in English so that other participants from Philippines should be able to understand me. So I would like to convey my highest gratitude and thanks to Institut Teknologi Kesihatan dan Sains Kesihatan Sidrap for inviting me. And congratulations to all those community and the committee who have worked hardly to ensure this project runs smoothly. All right, can I be the host? Okay, can I be the host? I want to design. Can change me as a host? Or lifestyle. And most importantly, we also having this aging population, and on top of that aging population, we also have this multi-morbidity, which increase the burden to the public health as well as in the healthcare system. And not only with the increasing number of the disease, the burden of disease, but in some places there are a limited access to the healthcare services. So this is all increase the burden of the healthcare providers to provide quality care. Now we move into the maternal and child health care. So in maternal health care, our what we call that um, sustainability development goal, still in certain countries we still did not achieve the maternal mortality ratio. In one of the country is Indonesia. We also have increase in number of mother with GDM in the maternal health. We also have many of those high risk cases of GDM because they are obese during pregnancy. And we also have high risk, all the high risk cases like anemia and so on. So in child health perspective, we also see the childhood obesity. Previously, we have a lot of problem with those people who are underweight, but now we are also having problem with the obesity and the emerging of infection and the vaccine prevention issues, and we do have still with the malnutrition. Based on the statistic here, as I showed, we can see that even though maternal mortality is reducing, but it still does not reach to the MMR target. All right. So similarly with the childhood healthcare problem, we still have this number of people who are malnutrition, but now we can see the number of children who are under age of 5 are increasing with the overweight and obesity. So with this, it's not being, we're not tackling or we're not taking care. So the probability of them to have the non-communicable disease will be very high. So are the community nurses and midwife prepare and address the non-communicable and the emerging infection disease spontaneously? Can we handle those all in one? Your answer will be yes and no, depend on our preparation, right? So why the advanced do matter in community and midwife? Because we have to tackle with the maternal mortality, especially those in the rural area, because in this rural area, the accessibility to the service is very limited, and they do not have a time buffer system. On top of that, we always have the issue with tree burden among the mothers. Delay in the information, delay in getting the services, delay in deciding when to go for the hospital. This is more of those causes for this maternal mortality. We also need to have this remote management because we have all those aging population. It's not that aging population is the issue. The thing is that the accessibility and the affordability to go to the healthcare centers. So sometimes they are unable to go to the clinic because of there are no people that can take them to the hospital. All right. And infectious disease, we are coming up with all those different emerging and re-emerging of communicable disease. So we need to have a system whereby we can track all those pandemic and all those outbreak immediately. And of course, everywhere globally, locally, and regionally, we're having a lot of workforce shortage and inequalities. We have a lot of issues with not enough of staff. So we need to have some effort to reduce that by using the AI technology. Okay. So therefore, we can say that it is necessary for the community nurse as well as the midwife nurse to have a digital innovation so that we can improve and we can cope with the challenges of future community. So what is health 5.0? The sounds look like it is more of that technology, but we are very sure, we know that when we provide the care, human touch is also required. But healthcare 5.0 is the human-centered technology enabled healthcare, whereby the healthcare 5.0 integrate AI, digital health, data analysis in providing the care and in assisting the healthcare provider in providing the care. All right. So this is the explanation that I mentioned earlier on. Human-centered healthcare, which we emphasize the integration. The word here is the integration of the technology with humanized and personalized care, meaning that you can use all those technology, but the human care, it must be still maintained and sustained. As what we said, innovation, cost-free response, and sustainability of care. And advanced digital tools. So you see, as we move on, we need to have a lot of advanced digital tools. Currently, we have that digital tools, but in future, we're going to need more advanced digital tools. So when you have all these digital tools, we have to ensure that our healthcare provider are able to cope with these advanced digital tools. And of course, when you have all those things, we cannot improve if there is no ethical and leadership support. So whatever you do, you have to have this ethical and leadership support, because anytime, anywhere, this ethical will be useful in terms of future any issues related to what do you call that, in terms of the ethical issues, like patients required to sue the hospitals. All right. So what are the characteristics of healthcare 4.0? Human-centered care, artificial intelligence, telehealth, and virtual care, Internet of medical things, data-driven decision, precision and personal health, sustainability and equitability care. It sounds very simple. We hear it everywhere. But now, we as a healthcare provider, we have to really understand what are those words mean and how does that help us in providing our care to our patient or our community. So are we preparing our community nurses and midwives to healthcare 5.0, or simply adapt to it? So what will be your answer? So it can be yes, we have to adopt, and you also have to be innovative, because you have to be, it must be work together in order for us to move on. All right. So this is some of those telehealth remote patient. This is some of those currently existent, maybe in some countries and maybe not in the maybe in some countries and maybe not in other countries, like virtual consultation, continuous monitoring, proactive intervention, geographical flexibility. So all of these there is, we are, even Indonesia is also advancing in these terms of telehealth and remote patient monitoring. All right. Okay, so what are we going all those digital, but you have to ensure that your ethical reasoning and your ethical approach is well covered, because in future there are many issues with the law and law in this discussion. All right. Innovation and care balance. Of course, when you have all those AI to assist you, you are able to provide the care as much as possible, even though you have the shortage of staff. So this is some of those, the future 5.0 continuous and midwife. You're going to have this digital health navigation, coordinating care role, community education and empowerment, as well as leadership innovation. So this is all those, what are the skills that we need to attain when you go to 5.0 continuous and midwife. All right. So when we talk about the AI in the community, of course, we must know that what are the feasibility or the opportunity that we have in our community healthcare. We cannot just simply say that, oh, it is good to have all those things, but the feasibility and the opportunity is not there. So it is important to have this telehealth for remote care, because as we mentioned, especially in Indonesia, where you have thousands of islands, in controlling the disease um, is not possible because of a scattered island. So you need to have this telehealth and remote care services, or AI supported clinical decision. When you have all this, you need to have the clinical decision AI supported. Mobile healthcare, everybody is aware, mobile health and wearable, and nurses technology mediators. So we need to train a nurse who are well versed with the technology, because there's no point of us talking about the technology when we are unable to have our nurses to help when we have all the issues. Because what currently happen is that when the nurses having those issues with this AI, when we have the AI issues, the one that we call is those from AI center. So which we have what we call that communication mismatch, because if you call those nurses who are expert in this information, they are trained with the information, they are able to help us with any what we call troubles that associated with the nursing care. So we have to look into our new job scope or our new title of job. That means that nurses, a nurse, informatic nurse directors there. All right. So example of digital innovation in community midwife. So this is one of the one of, I'm saying this is one of. I have my student who developed this birth preparedness and complication readiness web application. So this is in Padang. So the result was very good. We reduced the mortality rate by empowering patients, especially because the focus is more on the preeclampsia, because preeclampsia is one of the indicators in MMR. So we created all those things. So it really helps, especially for mothers who are very busy, who are working, who have. It's not that they don't know. It's just that the compliance is poor because of the current situation. Then we also had different types of fetal monitoring. Previously, we have all those manual. Now we have all those new technology. We have portable ultrasound. We have all those Doppler to ensure that the fetus is healthy and viable. All right. So what we're going to say is that we have to be smart. The community nurse, the midwife, we have to be smart. Smart in the sense of not only on the technology, we have to be smart in our nursing care, all right? Smart in our nursing care, and we should apply in our technology. Remember, technology is part of assisting us. So we have to be smart. So we have a lot, I think what I can see, we have all those Hana, Hana, Hana Charka, am I right? My pronunciation. They have a lot of programs to improve on the professional development. So another words of that is that you need to improve in the your 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 knowledge and practical, as well as together with your digital advancement. All right. So digital tool in maternal care, enhancement, communication support is you must be what will happen to the patient? People, patient will lose interest and lost trust on you. So at the end, your objective to improve on the patient will not be achieved. So it is very important, right? So do we need to have a global collaboration? Of course, you need to have the global collaboration. Why you need to have a global collaboration? You feel that your national is not good enough? No. The thing is that we are not talking about who is good, who is bad. The global collaboration is very important in terms of sharing, in terms of troubleshooting. Because when you have this collaboration, international collaboration, we learn, we share, and we learn from one another. All right. So this is part of this smart diagnostic artificial intelligence that I mentioned on. You have portable tools, you have all AI-driven screening. I think currently we are working together. I'm working together with this wound care from Dr. Vidasari. So she's doing on a tool so that they can have wound analytic, looking into assessment on the wound, so that whenever you go for the wound care, it can be improved. All right. So some example of what we have, what we currently have, is that, like Indonesia and of course UK, Australia, or all the European country, they are more advanced because of their economic status as well as the community education status. In Malaysia, we do have a few, and similarly with Indonesia. So I'm not going to go through, everybody knows about that. You can access through the website. So now we are preparing our community nurse. We are preparing with the what we call that, the midwife, as a community and midwife 5.0. So you need to have some basis on that. So in what I mean here is that the basis in preparing for the future community nurse as well as the midwife. So we need to look into the transformation of the curriculum. Probably currently there is some informatic subject in our curriculum, but now we have to transform that and make sure that we are the one who are the person who innovate and transform our AI for our healthcare program. And of course, we have to have interprofessional collaboration, lifelong learning, and also we have to be shared education responsibility. Remember, now, as a community nurse and midwife 5.0, we are more exposed to the research and innovation. And compared to the previous community and midwife, we don't say that they are lacking, but because of they are not being exposed with the research. But most of the time, the previous nurses are always involved with the research as the data collectors. But now we already move into our more higher level of responsibility. Now we are the one who are doing the research and provide suggestion on the innovation to improve our what do you call that, our community and midwife healthcare services. So because like one of the example, this one, I have a few students who um, develop, design all those webs to ensure like all those high risk pregnancy. That is also on stunting. They are also on AI on rehabilitation. They are also on compliance to management of heart disease so that they can avoid any readmission. So it is very, very important. See, the thing is here is that we are moving forward. The nurses, the community health nurses, all the nurses, we are moving forwards to a better and more advanced in our services. We are no longer only the bedside nursing, but we are also moving together with our advanced innovation here. All right. So this is the emerging trends, which we have to be well versed. All right. Okay. Connected with the rural health, digital empowerment, technology-driven personal care, strengthen the community. Okay. So this is part of, I just take one of that to show how much is this Indonesia is also growing in terms of the technologies. So make full use of that. The nursing, please make full use of the technology that they already have. All right. All right. So what are the framework for action? So we have to have all those for the student, learn digital health skills, and evidence-based practice, participate in any innovation project. For the lecturer, we have to make sure that the curriculum transform into digital, strengthen the global collaboration, and conduct rural nursing research. And for the administrators, they can always support all those what it is needed by the student as well as the lecturers. So evaluation, those days, the home visit, there's no more home visit, meaning that we can have all those telemedicine. Maternal health care, we can have all those variable monitoring. We can also have AI-supported decision making. And in terms of disease surveillance, we can always have those tracking system, right? All right, so okay, this is the part that I want everybody to take part. Okay, get ready with this, all right? Okay, I'm going to ask question. I want somebody to respond. Anyone? Okay. If a patient has to travel 4 hours to see a nurse, is healthcare really accessible? What is your answer? 4 hours in order to reach to the clinic.
Prof.
So it is not. That means that you have a lot of issues like global health inequality, rural nurse workforce shortage, aging population, chronic disease burden, healthcare disparity there. It will lead to all this, when they have to travel 4 hours. It's not only in Indonesia, in Malaysia, places like Sabah and Sarawak, they do have the same scenario here. This is from the Sabah and Sarawak. Okay. So my question here, okay, when you think about in the year of 2035, which is the one technology that will most transform community nursing and midwife? We have all the different of those things. Anything, and not necessarily from this one. You can say that. Anybody? We have. How do you how can you improve? Which technology that you all use, even currently? What technology you use? We have, okay. All right, you have those WeChat, we have what do you call that, Copilot, you have all those different type of AI. You have telehealth, of course. I think nowadays, because if you cannot go to that what do you call that, home visit, you can always have the telehealth, but you have to ensure you cannot say only, oh, we are doing the telehealth, this one, but the thing is that you need to have the accessibility. communicable disease prevalence, and health equity. For midwife, maternal mortality ratio, antenatal attendant, and skilled birth attendance. And can we improve what we don't measure? No, because if you don't measure, we cannot improve, right? Are we prepared for today's nursing and midwife student for the healthcare system 2035? The answer here is we have to improve, we have to prepare, but we have to ensure it is based from the preparation, the basic. We need to change the curriculum. All right. So the future community nurse and midwife will not be defined by the technology alone, but by the ability to integrate compassion, clinical expertise, digital intelligence, and global collaboration to improve health outcome for every community, including the pregnant mother. Remember, we have to integrate. We have to be digital intelligence. All right. In summary, okay, I hope I do it in time. Digital health innovation is very important. We have to go along with that. Those people like me, the old one who are not born in the digital era, we have to pick up, all right? And don't bully those old nurses or the senior nurses who are not, what do you call that, AI intelligent. We have to what do you call that, coach them. We have to pull them hand along because remember, the senior staff, they have well experience which they are needed in order to uh, train the new nurses. All right. Role of the rural nurse, very important now. We need to ensure that there is a lot of challenges in public health as well as in the midwifery, especially midwife in the rural health. So we have to make sure that we are well equipped in terms of our knowledge, skills, as well as our AI intelligence. All right. And of course, we always be connected with global by having all those webinars, by following all those conferences, by involving with any research. So you have to have all those research inclusive from different countries to improve on your research finding. And of course, we have to get ready with the human-centered healthcare. All right, with that, thank you. Did I over time? I have more time for that.
Yeah, thank you very much, Prof. Dr. Farida. Give applause to her. Yeah, very interesting topic.
Yes, thank
And
you.
we have 15 minutes time for the discussion, Prof.
All right.
So for all the audience, please raise your hand to ask
when they have the postnatal, we go for this home visit. Those days we need to go for home visit. And this
When they
mother
have
is
the
the
postnatal, we
anemic,
go for this
anemic
home
patient
visit.
who
Those
have
days we need to
lost,
go for home
and
visit.
we have to
And
go
this
and
mother
visit,
is
and we have to make
the
sure
anemic.
that
Go
the
for
diet
this
that they take
home visit.
must
Those
be
days we need to go for home
healthy,
visit. We
not
have
to be
this mother
expensive, but
and
we have to
we have
make
to
sure
go
that
for
can
this
help
patient
reduce
must be
hemoglobin
healthy,
development. One,
not to be
so
expensive,
because
but
of
we
the
have to
social
make sure that
academic
they
background,
reduce
we cannot suggest
healthy.
one
We have
very
to
high
because
standard of food, but we can make sure that you are the one who's going to identify what are the available source of food, but we cannot define all those things. And I have to go and check whether the hematamic or the iron tablet that you give state engagement between you as your patient, because that will build the trust between you and your patient as well as in the community. Remember, it's not about trust with you and the patient. Once you and your patient as well as in you, the community will develop the trust on you. This is what's happening in Indonesia. They have a lot of trust with all those midwives who have a very good culture sensitivity, what do you call that, the insight with the patient, right? So remember, AI is only assisting you to make your work easier, but you are the one who are more intelligent than AI itself. All right?
Yeah.
Okay.
All right,
Thank
Prof.
you.
Welcome, Prof. Farida.
Yes.
Ibu Dila.
Ya, Bu. Thank you so much
Yeah.
for
Our time is over.
Thank you.
So,
Alhamdulillah, the time is over.
ya, Ibu Dekan, Ibu Dekan, Bu Mariam ya, Bu Nurse Mariam.
Ya, Bu.
Apakah jadi mau memberikan sambutan, Bu?
Ibu narasumber dari Ibu Dr. Megi dulu. Nanti
Oke.
satu.
Nanti setelah itu ya. Oke. Baik. We give applause one again for Professor Dr. Farida. Very great material, and of course we appreciate and thank you so much for the knowledge.
Thank you, Prof.
Ya, minta maaf ya, saya tidak
Thank you, Prof.
berpantun. Mungkin ada siapa yang mau beri.
Kelas pantun ya, Prof ya.
Ya, saya tahu cuma itu saja. Pisang mak di bawah belayar. Oke. Masak sebiji di atas peti. Bila-bila rasa rindu saya, so jemputlah saya lagi.
Cakap.
Thank you,
Oke,
Prof.
bye.
Thank you,
Thank you,
Prof.
for the material provided.
Okay, thank you so much.
But for joining with us, Prof. See you next webinar, Prof. Farida.
Yes, okay, thank you. Assalamualaikum. And saya juga ingin mengucapkan terima kasih kerana semua yang able to join and able to engage with me, answer some of this question. And saya juga minta maaf because maybe tersilap, ada kesilapan yang mungkin bukan disengajakan atau itu yang baiknya adalah daripada Allah dan yang selebihnya adalah daripada kita. Okay, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Lalu Prof. Farida. Yeah. Well, ladies and gentlemen, now we are going to the next speaker. Welcome to Dr. Marina Magnolia Pitalardo.
You see,
It's
Okay,
not.
I will.
She will share the topic about analyze the burden and determinant of non-communicable diseases, including hypertension, diabetes, in rural communities and their implications for healthcare services, identify risk factors for child growth and developmental disorders, including stunting, developmental delays, based on local social and cultural context. But before she's going to talk, allow me to read her curriculum vitae. Our next distinguished speaker is Dr. Marina Magnolia Galardoninoble, a doctor in nursing science who earned her degree from Santa Paula University, Philippines. She also held a postgraduate diploma in women and development from the University of the Philippines. Dr. Ninobla recently served as the Dean of the College of Nursing and Midwifery at Good Samaritan Colleges and has extensive international academic experience, including a decade-long tenure at Oman College of Health Sciences as a health science specialist. All right. Dr. Marina,
Yes, you can hear me.
you have 30 minutes to 45 minutes, doctor,
Yes.
to present.
Hopefully I'll finish. No, from ITES, Muhammadiyah Sidra, Dr. Halipa, Professor Farida, our speaker, who I was listening, very interesting, AI, and then our distinguished speakers, Suki Fili and Nurhana, who will be next. Good morning, and to all our international colleagues joining from across the globe. Okay, welcome, and I generally I would wish to thank everyone, particularly the university for the opportunity to be one of your speakers. Okay, so it is truly absolutely an honor to be one of your speakers in this webinar. So, okay, for the session agenda, I have three, which hopefully I'll be able to discuss very briefly. I'll try to map out the dynamics, analyze the structural and regional epidemiology shifts, tracking non-communicable diseases, and of course the interlocking frameworks of the both maternal and pediatric chronic non-communicable diseases, and identify possible interventions. Okay, but before I begin, let me, of course, give my disclaimer that the views expressed today are entirely my own and do not represent the official position of my current or future affiliations. I also declare I have no conflict of interest to disclose. And at the same time, of course, I recognize the expertise of many people, as this presentation is a consolidation of my experience and my research work, and of course, trying to build the possible session agenda. Okay, so before I begin, can I ask everyone to please join the Slido if you have data or you have access to Wi-Fi? Is it okay to please try to scan the QR code?
Participants, doctor?
Yes, please, for the participants.
Ya, silahkan teman-teman, Bapak Ibu semuanya untuk bisa bergabung di slide.com. Maybe quiz or
Yeah.
anything else, Dr. Marina?
Did you see it? Were they able to? Let me check again, okay? So I can share. It's a quick funds already. Please vote. Try to see. Please select any of the following health conditions you've been diagnosed with, or
Ya, jadi semua partisipan silakan bisa buka di Google untuk slido.com
yeah,
dan masukkan enter the number ya
the
yang sudah
ones at
muncul
the phone.
ya. 1598030 nanti semua partisipan bisa menjawab. Ini semacam kuis ya Prof ya Dokter Marina.
Is that okay? So we can see. I'll probably give a minute, just 1 minute. It's not very hard.
Teman-teman sudah bisa mengakses?
Oh, only 11. We have 200 strong participants. I saw it, 200 strong participants.
Almost 300, almost.
Yeah, see, so I was hoping at least I'd get a 50 in 1 minute's time. Just a quick survey for our participants. I have 13, 14, 15. Okay. I think there's none of the above. How we wish we have none of the above. So my time is started 1 minute. It's 11:19. I started 11:12. So for you.
Is there any problem, teman-teman, Bapak Ibu?
21, 22.
Yeah.
Okay. Can you access it?
Tinggal klik saja pilih. Sudah masuk, nanti akan muncul questions and you can answer or klik centang-centang saja ya. Nanti dikirim.
Oh, what happened? What happened? I have 20 seconds. So only 10% of our participants. Maybe that's not, that would be fine. At least I have a 50 over 100. Okay. So we'll see the surprise.
Ya, please. Silahkan bisa klik.
So 10
And-
seconds,
and
and then I'll show the answer. 43 only. Maybe we will have I hope that we will have price for the 50th person.
Yeah.
Okay.
Give door prize ya, Dok ya.
Okay, so let's see. Because we have 300, so at least about 25% we can. Okay, so let's see. Let's see the answer. Aha. See? So we have, you can see the answer. Okay, this is the survey. We have 67% for hypertension. None. None of the above, I mean. Then you have 31 for, very good. We're still healthy. We have healthy participants. To our dear moderator. We have Diaplasm C, almost 21. Everyone is 21%. We have hypertension and diabetes. I have diabetes. 2 years already. So that's it. So at least we have a picture. We have hypertension, so atorvastatin probably. Is that it? Or okay. At least we still have healthy participants. Okay.
Yeah.
Thank you for your answer. That would give us at least at least a glimpse of our participants. These two basically are our concern, right? So let's see if this match the epidemiological studies we have. Okay, thank you everyone. So let's move on. I'll share again my slides. How this our participants fits into our global trends and facts. Okay, so according to epidemiologic study right now, there are 18 million people who died before the age of 70. This is according to our WHO non-communicable diseases of 2023. And of all NCD deaths, 73% are concentrated in LMIS, low income. That's right. So the big four are particularly the we have cardiovascular, which is 19 million. Cancer is 10 million, and respiratory 4 million, and diabetes at 2 million, which drive 80% of premature NCD deaths. Likewise, modifiable drivers such as tobacco use, physical inactivity, and harmful alcohol, poor diet, these are the things that we already keep talking Additionally, traditional infectious diseases coexist with long-term chronic non-communicable diseases. And we, as mentioned also by Professor Farida, there are rural disparities and developing networks face severe geographic, staffing, and technical constraints to handle long-term care demands. What do we mean by this? Particularly, these are the transitions that goes on with the element of environmental mitigations that we have that was identified ever since. Primary healthcare fragility, the prevention versus treatment and follow-up dropouts. Particularly, the community has always been challenged with this prevention, treatment, and follow-up. And I think particularly during the time of discussing the AI, no, these are one of those that was emphasized. We hope that we can access through AI, we can particularly access this because this is a long-standing problem. It's not something new. It's not like just today we learned about it. Particularly, it is growing, it is trending, and it does not only emphasize to our rural communities, but even in urbanized area, dropouts are also increasing. Okay, so let's look at the profile. So these are the following. What the numbers may look like, there's this tendency for us to be a bit scared about numbers. But the most important thing that we would like to emphasize here is you can see, no, notably there, no, higher than the global baseline. The region health profile increased, particularly when you get the global baseline. So right now, this underscores the critical regional demand for targeted life course, maternal and pediatric intervention frameworks. So you can see that we have the baseline now, particularly here, is increased for us in the region. And this is very timely. Your webinars like this, so that we can meet up, we can discuss this, as this is something that we cannot just simply sweep under the rug. Okay? It's something that we discuss, and at the same time, we try to plan together. Okay? So particularly, the structural determinants, number one is commercial marketing. This to me is highly commercialized. It's not new. Everybody from the time that when I was a kid, when Professor Farida asked, will it be the same in community health nursing? I immediately said no, because particularly the food that we eat when we were children were not the same right now, with highly commercialized ads and with the advent of food delivery. I think you have Grab there, it's easy. Everything is at the tip of the hands. So, and highly processed food is evidently, if you try to see, probably one of these, if I may suggest to the university, one of the possible research that you can do is you try to look at the menu of what's in the Grab food, if it's Grab there or any other, what you call Food Panda or what. So, and try to see what are the food. I was looking at it, and you have all iced tea, milk tea, and all, right? And highly processed, sugar sweetened beverages. Okay, rapid urbanization, which the unfortunate event is that it altered our native food supply chain. I'm sure there are food right now that you can remember when you were a kid, that probably, or a menu of your grandmother that's not there anymore, or only a few people eat. I remember I have my mom has a menu, and the food, it's practically hard to prepare. It's made of coconut milk and all. So I was imagining amongst my siblings, we don't know anymore how to cook the right way, because everything is, the traditional way, I mean, because everything is pre-packed, everything is, you have sauces that's ready, no, and even the coconut milk. So these are the things that hopefully we the tendency is for us to bring again, okay? And likewise, we have the socioeconomic status. Low-income families face unequal access to fresh produce, living in urban food deserts that leave them vulnerable to metabolic risk. I think this is very self-explanatory. Okay? We understand that diet and lifestyle has to do with socioeconomic status. And particularly for us, the unfortunate event is those organic things that does not have, uh, that you would have to bring or to buy, they are more expensive than, or local products to us here are more expensive than those that are readily available, particularly made from or imported products. Okay. So likewise, how do we prevent this? Can we prevent it? Of course, as nurse and midwives, we already know that the best time is, particularly for maternal and child, we have what we call the golden window for prevention. The earlier, the better, right? As we say, early modifiable risk. That's why as nurses and midwives, we always ask, very important, what's the lifestyle habits, what's the food that they take, okay? Because chronic diseases during adulthood are deeply rooted to exposures, particularly during the fetal development. And the mothers are our best hope at the time when we can catch them and we can modify, particularly we can encourage them to a healthy pregnancy, a healthy lifestyle, no? And likewise, intergenerational impact, mitigating risk early breaks the cycle of transmitting NCD vulnerabilities from parent to child. I remember my professor. The funny thing is, when we were discussing this, it stuck to us, no, in the class. He practically told us, my diabetes is supposed to be non-communicable, but it's communicable. It's actually transmitted by my mother. The food that we eat, I was still, I think, a first year, in college at the time. And I was thinking, oh, I realized that's why amongst my brothers, they have increased blood pressure, because the tendency is my taste bud is more accustomed already with a little salty and more. So that's at the time when this was during 1980s, huh? And right now it's readily available. We all know that it's actually passed on. Habits, lifestyle, particularly diet, no, and access to healthcare is passed on. So likewise, systemic global milestone, we can correlate this to congenital baseline metrics, because as we can see, amounting to 8 million children annually, are born with congenital condition. This is according to NCD Alliance of 2022. So particularly, we try to maximize outcomes, which requires connecting early screening. Of course, we already know the I was a student, I think, when early newborn screening was being introduced, and it was so new. And right now, we have AI that could help us, no? But try to have our early detection, which is actually not the cure, but actually the best way for us to cure, because as we say, prevention is better than cure. Okay? So likewise, we have the intergenerational escalation, the transmission cycle. I think everybody knows this. Us nurses and midwives, or even the other participants, poor maternal metabolic environment alter whatever is, and we transmit it to the fetus. And particularly, this predisposes the child to early obesity, metabolic syndrome, and adult NCDs. Okay, so if you can see here the transgenerational loop, once maternal metabolic disturbance is there, you have fetal epigenetic alteration, accelerated adulthood, adult presentation. This adult becomes mother, okay, particularly women, because that's the one that passed on, to the fetus. So generally, this becomes parent, and then the cycle goes on. Okay. So poor maternal health actively programs the next generation's chronic illnesses. So second part, let's go to maternal health and gestational programming. Okay. So maternal NCDs, perinatal burden, you have here 18 million women die of reproductive age die each year from NCDs. I keep telling my students, these are numbers, and we can always discuss this, and if we can, it's readily available in the internet. What is the most that we can actually emphasize our students? To me, the most that I emphasize to my students is pregnancy is supposed to be a it's a wellness situation. It's a wellness state. Women should not die, even the child should not die because they're pregnant. It's just unfortunate that women have to die because they're pregnant. When it's fact, it's not an illness. So we can see this happens. Perinatal vulnerability, women in the perinatal phase or up to postpartum face unique susceptibilities to chronic diseases like pregnancy-induced hypertension. Okay, when previously I always say, because as a midwife as well, the most one of the most common that's being asked to me is, why do they have diabetes when they were not pregnant? They were not diabetic. The same thing happens in hypertension. So these are certain health teaching that you have to emphasize as you go along, because definitely we all know, even anemia, these are physiologic anemia and PIH and diabetes or gestational diabetes. Likewise, comorbidities does not help. If they have existing problems already, you can tell them. That's why early detection and early prenatal checkup, continuous prenatal checkup is emphasized. Okay, so meaning there's a double burden for them when they have comorbidity, and at the same time they're well, and all of a sudden they become vulnerable to physiological changes of the body, which makes them susceptible to certain conditions as mentioned. Okay, so these are the realities. The 2 in 3 threshold, approximately 2 out of every 3 deaths among women worldwide are driven by underlying NCD. So it's not true that they die because of childbirth. It's true that we suffer loss of women, of mothers, of child, because of the underlying non-communicable diseases. Normal pregnancy changes frequently mask chronic symptoms, as we have mentioned, physiologic changes. So these are things that we emphasize. And particularly in our community, what I have noticed is, there's this tendency that I don't feel I'm safe because I don't have diabetes. My family does not have hypertension. I don't have hypertension. Then all of a sudden they even become with this edema on their feet, and then so that's why it's very important for us in the community to continuously emphasize all of this, okay? Physiologic changes of pregnancy. Now, the 3 myths masking NCDs. I particularly like these 3 because, firstly, the first myth is that it's women only have to think about reproductive issues, when in fact, women's health issues are solely defined through their immediate reproductive childbearing capacities. They would always say that. When in fact, it's the other way around. We equally suffer the same chronic diseases with our male counterparts, like heart diseases, hypertension. At the same time, this also follows with our gender bias, that it's actually male dominated. And the third is that wealthy fallacy, that the assumption that NCDs only affect the rich people, quote unquote, who can afford uh, rich foods. Okay, when in fact, if particularly if you have seen our regional statistics, it does not. It does not translate to that. What we can see right now is that even low-income countries uh, suffer the same. They have equal. We have equal chances of having NCDs, just like the rich countries or the first world countries. Okay, sorry. Then you have the following obstetric transitions. You have the stage 1, stage 2, stage 3, stage 4, and stage 5. Particularly for the stage 1, scarce structural resources dedicated directly to basic prevention of maternal health. Okay? What do we mean by this? Of course, all the time, we wish to emphasize how prevention is the best cure. Okay? Stage 2, the critical lack of facility care. No? This is, I think, common in our rural areas, particularly here in the Philippines. We still have areas that are hard to reach by our healthcare workers. Okay, and that's why we were hoping that through AI, we can, it will help support our monitoring and reporting. The stage 3 is the 3 delays. I think this is particularly we all know as nurses and midwives, no? The delay in seeking, access, and receiving care. The stage 4, the current majority right now, mortality driven by pre-existing chronic conditions and NCD-related pregnancy complications. That's where we are right now. And stage 5, theoretical endpoint, where chronic metabolic NCDs emerge as primary cause of maternal death. Okay, so hopefully within this, we can try to find and allocate our resources, no, in these stages so that we can prevent going, to the most the worst case scenario we have. Okay, so what are the drivers of maternal NCDs? We have the first, obesity trajectories. That's one. I think we all understand obesity right now is increasing, not just for women, but even for children, which we will discuss in a bit. Okay. And then, of course, you have the urbanization barriers. We understand, as we have mentioned, how food, well, I think this particularly, this became more profound during the COVID, during the pandemic, where everything was being delivered to us, and we just haven't seemed to get back to the normal. No matter what we say that it's normal now, there was no turning back. We became more dependent on even in trying to buy stuff. We don't go to the groceries anymore. There even the going to the pharmacy. Okay, we can actually pick up the product. I think convenience. There are good to it, and there are sometimes advantage to it, and there are those that we have to compromise. Like particularly for me, our neighbor approached me, and she was telling me about a certain prescription of the doctor. And I told her, you go to the pharmacy because they would tell you. Then she said, but it's hassle, okay? But I told her, isn't it important that the pharmacist will tell you? Because there are certain in the prescription that sometimes you cannot read, right? So I don't, particularly if pharmacists are the best person to tell you what the drug is about, no? And they can actually tell you even the side effects and all. And then, okay, that's what she told me. So these are things that we have to compromise, okay, during the time of COVID. Convenience versus our, and to me, that's where AI would come in. And as mentioned by Dr. or Professor Farida, this is one of the possible dangers. If AI will never replace that, but at the same time, it will also, we have to also face the fact that this could happen to us, no? The loss of touch. Anyways, we move on to advancing maternal age. Okay, steady increase in pregnancy at older ages driven by workforce participation, leading to pre-existing metabolic vulnerabilities. Okay, I think this is very self-explanatory. I remember the risk factors for too old, too young, too many, too sick. You remember the risk factors for pregnancy? Too old, 35 right now. Too young, 10 years old. Too many, more than 4. And too many conditions, like someone is sickly. Okay, so these are one factors. Of course, the gestational stress test. Pregnancy demands accelerated or underlying or undiagnosed NCDs, which heavily exposes the mother and child to stress, no? And even possible diseases, uh, which is most of the time brought about by uh, poverty or low income status. So when we talk about pregnancy and all, there is such thing as what we call the hidden maternal NCD, and that is mental health, which is right now one of the topics that, of course, during the pandemic also brought us. This became more profound, not just affecting certain population. When I was a student, there were certain risk factors to this. We understand when we were discussing psychiatric nursing, and at the same time, when we were discussing about pregnancy and postpartum, we were discussing who are the most vulnerable to postpartum psychosis, to postpartum depression. Okay, but right now, even children, even young ones, it seems like it is mainstream. Okay, anyone is a possible candidate of mental health. Okay, so the perinatal mood and anxiety disorder encompass a wide clinical spectrum, including, generalized anxiety, panic disorder, the PPD, of course, obsessive compulsive behavior, no, and the like. Okay, so at the same time, systemic and biological consequences that can be brought about by this is the psychological strain for the and the fetal programming links. These two, no, through extreme stress and psychiatric condition may trigger systemic maternal inflammation, and at the same time for the fetus, elevated maternal cortisol levels alter fetal programming, raising long-term CD vulnerability. These are science-based, and it's not like it's hidden, and still with the stigma of mental health, uh, going to a psychiatrist or someone has to carry multiple burdens. This and who the society has a lot of expectations when it comes to being a mother. We still have a lot of expectation. You have to be strong for your children. You are expected to work. And if you are, to work at home, even if you are working, the double burden, these are all related to, and it's an NCD as well, okay, that we have to watch out for, okay? So I want to discuss briefly about maternal outcomes and SDG so that I can relate this to, because as a nation and likewise as a region, we are all gearing up towards sustainable development goals. And always we emphasize good health and well-being. That's us. That's directly related to us, okay, as nurses and midwives in allied health. And at the same time, zero hunger this time because we're discussing about stunting, growth stunting of children. And okay, so these are the two, the target 3.1 and target 3.4. Of course, there are still a lot, but these are the ones that directly relates to my session right now. Okay, so we discuss intrauterine. I understand all of us since we were discussing about okay, maternal hyperglycemia, and of course the epigenetic changes, okay, which we discussed just a while ago. Environmental change, of course, can affect the child or alter the child all until he becomes an adult or she becomes an adult. So anything, we've been saying that anything that the mother is taking in, I remember, as I said, we inherit diseases, certain diseases, quote unquote, we inherit them. We're more vulnerable to certain diseases. But there are also those that behavior of the mother or the lifestyle or the habits of the mother, particularly during the time of pregnancy, exposes the child until they become adult to certain NCDs. We didn't have to alter the DNA. We didn't have to. But at the same time, it has particularly in the health has affected, and this will go on until he becomes an adult or she becomes an adult herself. Okay? So in poor households, the health and nutritional needs of women are often subordinate to those of other family members. In many cultures, women eat less and least, a practice that is exacerbated during times of food scarcity. I want to ask, if I may, is this still common to us in the rural area? Because when I was still in high school, I remember really women are take the backseat when it comes to access to education, to food. No, it doesn't have. I'm not even saying that they don't provide, but we always take a backseat. Okay, is this still common in Indonesia or even in Malaysia? If someone can tell me, food scarcity. Does it still follow that we provide for the men first because they are the providers, and the women will take a backseat? Or this statement is not true? Anybody? Ah, the chat. Yes, I can access it. Oh, okay. Good morning, Dr. Ninonda. Okay. Okay. So I think these are particularly true in some areas. I don't think it's true right now. So I don't know. This is just one. This is according to social determinants of maternal health framework. Okay. So there is such thing as that they call nutritional hierarchy. Social and cultural hierarchies often mean women eat least, last and least, compromising their nutritional intake during critical preconception and gestational window. And at the same time, nutritional neglect during pregnancy damages maternal health and restricts fetal development, which reinforces, as we have mentioned, the intergenerational, transgenerational uh, passing on of NCDs. So we move on to the next, which is almost my last. We have the child and pediatric nutrition, stunting stigmas, chronic malnutrition math, and systems-based clinical integration. So what's the number? We have 2.1 billion children and adolescents are affected globally by growth stunting. Okay. Accordingly, we have here severe global inequalities is still very much present, and at the same time, disability and development affects 174 million years lived with disability, restricting educational achievement and social potential. Okay. At the same time, we have unhealthy behaviors such as sedentary activities, processed diets, and active passive tobacco smoke. No? And children right now with the social media, exposure, unless we do something about it, to me, social media does not brings more harm than good. Social media per se, I'm not saying access to internet or access to resources, but social media by itself, to me. If you wanna reconnect, reconnect with through face to face, calling your friends, no, meeting up. But social media, I don't know. So this becomes more the certain risk behaviors become more prevalent because of social media. And one of them, of course, is the nutrition, as I have said. Okay, I don't know. Maybe somebody can dispute what I said, but that's how it is for me. So we have 86% of premature pediatric NCD deaths among low to middle income countries. So we can see all this transition from. Okay. So clinical manifestations, what do we see? How do we see? What are the signs and symptoms, quote unquote, of what we have been mentioning, or the pediatric crisis? You have pediatric hypertension, you have early onset of type 2 diabetes, and of course the chronic respiratory diseases. This does not include the lymphomas. These are the first top three. Okay. And we also have blood dyscrasias, but particularly pediatric hypertension. I was with my student one time, and then I was surprised that a 13-year-old, the BP is 130 over 90. I was surprised. Like, I don't think 13, no, I can imagine probably 18, but 13. So I was like, you let him sit and let's take it again. So it's the same. So, and these are, we have younger population whom we thought when we were children or we were teenager, these are also old people's diseases, right? On this, but right now we see them. To us, as a child, you get cuts, you get wounds, probably quote unquote fracture because it's part of growing up. But hypertension, diabetes, that's not the thing we used to, I remember, that we would have when we were kids. Or probably, again, my professor said or emphasizes that the detection now is better compared when we were. So those are the things. But there is really an increase. Okay. So you have here the pop. What happens? Why do we have this? Unhealthy diet, physical inactivity. And these are self-explanatory. Overweight children, again, with the food access and the type of food that's available. Okay. During the early 2000, I remember when my children were still in grade school, even in high school, there was an effort for the school to limit the food and make the menu in the in the cafeteria more nutritious, but they found out that the students are not keen on buying them. And see, so the school, during the PTA meeting that we had, the Parent Teacher Association meeting, we were discussing because it was actually one of the suggestions of the PTA members. So they found out that the students are not encouraged or inclined to buy healthy food. Okay. So physical inactivity, that's common all day long, the social media. So even as adults, there is this tendency for us to be like that, more so for the children. Okay. When unlike when we were kids, I don't have to emphasize, we go out, play. As that's what I said. It's about time people go out to meet people, not inside their phones. No? These are things that you can. Okay, developmental delays. Okay, for full disclosure, my son is diagnosed autistic. But he was mainstream and he's now an engineer, a project engineer in a company. And I got lucky because during the time, the 1990s, no awareness about autism, about ADHD, all of these things, were not readily available, particularly for us here in the country, in the Philippines. So we only have, I think, 2 developmental child specialists, and I would have to wait for 7 months for him to see my son. See, so it's something like that. So right now, developmental delays. So it's good thing that we became more aware of this, but still, awareness is not what we want. What we want is more on access to, no, and to treatment, and at the same time, acceptance, no, in the society, even for the government, no, for our policymakers to prioritize our people with disabilities, particularly for those with cognitive and language delays and all. Okay. Motor and physical growth, you have gross and fine motor coordination and so on. We have stunting link. Physical stunting is a clear indicator of cognitive limits. Okay. So developmental milestones frequently remain unassessed until primary school. As nurses, we know about the developmental tests, right? Okay, so I don't know if you're using Denver developmental test, because to us we made similar to it, the Metro Manila developmental test. So again, it's one of those that are not prioritized right now. So as nurses, it's embedded in our, no, it's mainstream, it's included in our curriculum, the growth and development. So probably we can emphasize on this. One of the possible research as well that the university can endeavor is the developmental milestone, or the assessment of developmental milestone. Okay. So we have here the global epidemiologic trajectory and the systemic occurrence and action. So this is the trajectory and these are the action that we can take. So we've mentioned already the occurring rates, early detection windows, and workforce capacity. Okay. So I think in our school right now, even in college, how do you mainstream a person with different ability? College, I had that. We had to It's good that I was working in a university, so I brought my son to the university, and he was actually mainstream, quote unquote mainstream. But just the same, people with special abilities or different abilities require teachers to teach them. Okay, He got easily bored with the subject and all. So this is at that time when he was 17 years old. So what more with the students, no, who are children, okay? So workforce capacity is also scarce right now. Okay, stunting leak and the NCD. So stunting is not just about short stature. Early nutritional scarcity forces the body to adapt to a high-fat, low-caloric environment, programming it to restore excess fat later in life. So during the adult, when a stunted child gains access to cheap caloric-dense foods later in life, their metabolism is overwhelmed, triggering a quick insulin resistance, obesity, and type 2 diabetes. Okay? And this is how it looks like. So the 27.4% in the Southeast Asia alone, you have the global, you have 22.3%. So meaning we have an increase again for the Southeast Asia. For us here in the country, I saw it in one of when I was reading through it. The stunting affects nearly 1 in 3 Filipino children under the age of 5. See, this is very recent, 2025 statistics. Of course, you already know this. This is how we compute stunting, right? Okay. So local cultural dietary taboos. I think I mentioned this already. Okay. There are harmful nutritional beliefs as well. I was going to ask you, what's the harmful, if you have one, is it still common? Okay. Can somebody at least in the chat room or speak? Is there a certain beliefs in Indonesia or even Malaysia, if you would allow me, or Philippines, regarding how we eat, no, or food? To us here in the Philippines, particularly in pregnancy, if you eat banana, double banana, you have twin banana. Have you seen one? Twin banana? Ah, you will have twins. If you are going to eat, squid, because they have tentacles, you might have as a child with extra fingers. These are certain beliefs, no? So I don't know.
Yeah,
You have something like that, Miss Moderator Tris?
similar, Doc.
You have, okay? Can you tell me what is it?
Similar with the
You have something like that? Mitos and hamilan. What's okay? You have food for during pregnancy. It's still common here to us. It's still common. No, there's still people who believe it. No, see, these are things that we have to address, right? Again, myths and misconception. When in fact, banana is good, right? Or squid is good. So they avoid it because of certain cultural beliefs, okay, or
yes,
misconceptions, okay? So we move on. We have, see, for us, to me, the most important is this, the avoidance of colostrum. Is still common, probably in certain areas. Okay? Traditional beliefs in some Indonesian and Philippine village lead families to discard colostrum, depriving infants of crucial protective immune factors. Is still common with you in your country, in Indonesia or even Malaysia. I still have some women who will say, that's no, that's a spoiled milk. I have to remove it because it's yellow. So there is, although it's not more common than when I was a student or when I was starting as a nurse. Right now, because again of access of, one of the good things, access of social media, mga people now, and because of uh, economic situation, people now, women understand the colostrum already, the importance of colostrum. Okay, new 5 minutes. Okay, 5 minutes. Okay, yes. 1 hour already, miss?
yeah.
Okay. So this is the 5 minutes. Okay, so we move on. So systems nutrition in NCD care. So you have pediatric burden, nutritional dividend, and systemic gaps in action. As mentioned a while ago, what can we do and how do we, particularly, uh, um, how can we help our country when it comes, or even the women in our community? Uh, so strategic actions, I'm just on time. Primary care scarcity and supply chain breaks, modern realities and shortages, extreme global deficits. What can we do? So the primary healthcare is still part of our um, best option and health is the primary health care. Us as primary care health givers, right? So the roles of the nurse and midwives, NCD screening hubs, nutritional guardians, social bridge builders, which a little bit was already emphasized by Dr. Farida. So I continue to advocate for us to be good listeners and good health educators, okay? So these are the consolidated strategic action that we can do, which was some of this. Digital policy reform was emphasized by Dr. Farida. We have, of course, for us as maternity, prenatal tracking. Actually, it's not new. These are old stories, old tricks. But still, if we become us, we equip ourselves with training, we probably build AI that could help us, no? We can survive all this with the action planning that we can do. So you have collaborative efforts, systemic integration, cultural competence, and workforce scaling can help us build and prevent NCDs among maternal and child and both stunting for our children. Okay, so let's contribute to sustainable outcomes. Nurses and midwives can take on more prominent role in NCDs through counseling, managing chronic conditions. It's not new, it's old. But how do we innovate? What kind of innovations can we do? I think, okay? So conclusion, non-communicable diseases are no longer just adult conditions or high-income country problems. They are deeply rooted, intergenerational, and affects not just the women, I mean not just men, but women as well. Okay? So thank you very much for your time. This is me. Salamat po. Okay? Very good. Do I have time? Okay. If you have some questions.
Okay, thank you so much. Yeah, thank you so much,
Am I on
Dr.
time?
Ratna.
Dear moderator, am I on time?
Yes.
Very good. It's good. You
Time
should
is
Haslinda.
Yeah, Ibu Haslinda.
Okay.
Haslinda, ya.
Hello, Haslinda.
Yeah. It's yours,
Assalamualaikum.
Haslinda.
I want to question about if the role of rural nurse and midwives shift from being mere clinical care providers to becoming drivers of the community health ecosystem. What new competency
Go ahead, please. If the role of rural nurses and midwives shifts from being mere clinical providers to becoming drivers of community, what new competencies must immediately be integrated into educational curriculum? No? Local data analysis, leadership, rural sociology. You're asking me if any of these three, because I think these three are already embedded. One that I would like to emphasize is one. The most important is advocacy. I think it should be embedded in our curriculum how to advocate. Particularly in leadership and management, we should have another one a layer that would help us how to do policy or the process of policy, because usually it's in the higher education, in masters, where we are taught of policy making. But I think in as early as in our undergraduate, we can actually introduce. The second that I would like to emphasize, if I may, this is just my opinion, being a nurse educator and a community health nurse at the same time, a maternal health nurse at the same time. How can we translate? We are teaching this already in health education. We are taught how to communicate with our community. But I think right now, the best is how can we detect or how can we counteract fallacies or misconceptions? What's the best way to do that? Which is already in our curriculum. Okay. And at the same time, I think one of those, there's also the nursing informatics already, which could embed the AI. But I think we should emphasize ethical, how to ethically use AI, right? It's embedded, nursing informatics is embedded to us, but how can we translate this behavior of using AI? Okay, I think those are. Did I answer your? I hope I answered them. They're already local data analysis, leadership. They're already embedded in our. We have CHN. We have right. So I think just for me, particularly the use of social media as well, and fake news. There's a lot of fake news right now. I don't know. To me, even I myself, maybe how to detect a fake news, because it's
Wow.
particularly for the undergraduates. For us teachers, we can. But how can we teach our nursing students to detect fake news? I think we should emphasize that part of our fake news or misinformation or disinformation. These are very common. They're common, right? So to me, that's it. Very practical. Anybody else? Please.
Thank you so much, Dr. Marina. How about Miss Halinda?
Thank you very much. That's
It's
really
good,
amazing.
Miss Hasminda.
Maraming salamat po.
Maraming salamat. Okay. Do you know Dr. Agus? Oh, no. Because he's the one who invited me. He's my classmate in St. Paul from Indonesia. I might visit you soon. I'll be in Brunei pretty soon. So I have my email. You can display it if you like soon. So you can actually, if there are questions, right? Well, we can. Okay. Regarding the aggressive marketing of ultra-processed food and sugary drinks in rural, what kind of urgent public policy should be implemented? Can nutrition, education, and local health centers really compete with giant commercial ads if the government doesn't enforce it? Your question is as good as mine, because for urgent policy, right now we have EO for the milk code. Do you have something like that as well? A counterpart, a milk code. That's one of the most, I think, landmark policies we made for the country, in our country. The milk code or the executive order number 51. And then it's ultra emphasized for our, whenever they buy milk, we have, or the commercial, we have a commercial for milk products. They include a certain portion that there's no substitute for mother's milk. Now, when it comes to what kind of urgent policy, it's emphasized in the should be implemented. Okay, nutrition education. For me, it's as good as your question is as good as mine. I cannot. Particularly if we talk about urgent policy, what is it? The most, to me, I guess, is coming up with list of nutritious food. I can only share to you what we have in the Philippines, which we're practically a bit happy about it. One is all our food, I hope it's the same for you. All our food, there is junk food. They included junk food, quote unquote, but they have included certain micronutrients. They have that. The second is, as I said, the milk code policy, and which I think is all countries have been participative about emphasizing how important is the mother's milk through the Mother Baby Friendly Initiative. But for urgent policy, I think policy is already there. It's just a matter of implementing them.
Yes, implement or not, yeah, doctor.
Right? Because it's there. I cannot. We have it there, but it's a matter of implementing them. Growth stunting, we have. See, even
Big
the commercial, we have to remove commercial ads. When in fact, when you are doing, isn't it, when you have, there's commercial, there's ad. Oh, we remove. I think again, for Ernie, to me again, social media use, that's right. Because all of this relates to social media use. The ads there. When you are watching something, right? Then all of a sudden, there's the milk tea. Or they're going to show you food. Or not just that. Some things that you do not need, but makes you need it because it's there. Okay? So I hope it's a matter of implementation. Policies are there for us.
Thank you so much for the answer, Dr. Marina, and thank you
I
for
hope, Ernie, I answered your question. Sugar tax.
very good questions
Not
from
that in the Philippines.
Miss Ernie.
No, our country, we have sugar tax already. When we buy carbonated drinks, we have more. There's already. So, alas, what more can we do? It's just a matter of implementing them.
Yeah. The same with Indonesia country, doctor.
I'll see you soon. Okay? So I thank you for the opportunity to have been. I hope I did not do overtime. I think I'm just on time. Thank you very much. I'll see you. I hope I can collaborate with the school and to all the people who are the participants. I wish you well and no NCD for us, hopefully. Let's eat well. Let's balance our life-work balance. And may Allah be with you. Okay? Thank you.
Okay, welcome. We hope so, Dr. Marina. Yeah, all the community or society very healthy. Once more, thank you so much for join in the Zoom and for the great knowledge for us. Yeah, keep close to her. See you next time, Dr. Marina.
Thank you, Dr. Maggie.
Well, ladies and gentlemen, kita sudah memasuki duhur ini ya. Sudah melebihi ya Bu Mariam.
Ya, yep.
Yes. Berarti kita break dulu untuk
Ya.
15 atau 30 menit.
Ya, termasuk
30 menit, karena sekarang sudah jam 12.30. Kita
sudah
break.
sholat duhur juga.
Iya ya. Nanti kita mundur setengah 30 menit ya, Bu Mariam. Tidak apa-apa.
Bisa betul.
Atau bagaimana saya ikut ini audiens, karena kita molor 30 menit tadi untuk mulainya juga. Jadi we start again at 1 p.m. Is it okay? And after this we speaker Ibu Mariam and also Dr. Zulkifli ya nanti ya. Bapak Zulkifli.
Nurjana, ya.
Silahkan teman-teman untuk bisa beristirahat terlebih dahulu sambil makan siang dulu juga boleh. Salat dan makan.
Mohon izin panitia untuk sesi 3 mohon dibantu untuk share screen nantinya.
Oke, boleh Pak. Siap.
Oke, terima kasih.
Speaker sama-sama Bapak. Speaker 3 nanti Pak Zulkifli dulu, kemudian the last speaker Bu Mariam Ibu ya.
PT Prima Medicina Hanacaraka terdepan dalam melatih tenaga kesehatan untuk membangun masa depan Indonesia yang lebih sehat. Selamat datang di PT Prima Medicina Hanacaraka, lembaga pelatihan kesehatan terkemuka yang berkomitmen untuk mencetak tenaga kesehatan profesional yang siap menjawab tantangan di masa depan. Sejak awal didirikan, kami telah berkontribusi dalam meningkatkan kualitas layanan kesehatan melalui pendidikan dan pelatihan yang berkualitas tinggi. Kami percaya bahwa masa depan kesehatan bangsa terletak pada tenaga kesehatan yang terampil dan kompeten. Oleh karena itu, misi kami adalah menyediakan pelatihan yang inovatif, berbasis praktik, dan sesuai dengan standar nasional, para telah memberikan layanan terbaik kepada masyarakat.
Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Halifah, Direktur PT Prima Medicina Hanacaraka. Hanacaraka Training Center Indonesia adalah salah satu anak usaha dari PT Prima Medicina dalam bidang pelatihan dan peningkatan kompetensi SDM kesehatan yang telah terakreditasi tahun 2023 B akreditasi oleh Kementerian Kesehatan dan tahun 2025 telah terverifikasi oleh Kementerian Tenaga Kerja. Alumni Hanacaraka telah menyebar di seluruh Indonesia, adalah sekitar 11.000 peserta yang menyebar seluruh Indonesia, dan lembaga institusi yang telah kerjasama dengan Hanacaraka Training Center Indonesia sekitar 70 lebih lembaga pemerintah maupun swasta, rumah sakit, puskesmas, klinik, maupun lembaga pendidikan. Komitmen kami menghadirkan layanan terbaik melalui keunggulan yang menjadi nilai tambah bagi setiap peserta dan mitra, trainer profesional, metode interaktif dan aplikatif. Hanacaraka Training Center Indonesia punya layanan Hanacaraka Care dan jejaring kerjasama. di mana Hanacaraka Care adalah alur pendampingan peserta secara menyeluruh dari awal kegiatan pelatihan hingga pasca pelatihan untuk memastikan kompetensi terrealisasi dan berdampak di tempat kerja. Jejaring kerjasama kami dengan rumah sakit dan pasienkes, dinas kesehatan, perguruan tinggi, organisasi profesi, perusahaan BUMN, BUMD, dan perusahaan maupun instansi lainnya. Komitmen kami hari ini untuk kesehatan Indonesia dan untuk peningkatan kompetensi tenaga kerja yang lebih baik untuk esok. Hanacaraka Training Center Indonesia akan terus berinovasi, memperluas kolaborasi, dan memberikan layanan pelatihan terbaik untuk mencetak tenaga kerja dan tenaga kesehatan yang kompeten, profesional, dan berdaya saing global, sehingga layanan yang diberikan untuk meningkatkan kepuasan pelanggan pasien yang diberikan layanan menjadi safety. Misi kami adalah menjadi pusat pengembangan kompetensi tenaga kesehatan dan tenaga kerja terpercaya dan terdepan di Indonesia. Misi kami menyelenggarakan pelatihan berkualitas, inovatif, relevan untuk meningkatkan kompetensi dan mutu layanan kesehatan dan tenaga kerja. Nilai kami integritas, kompeten, inovatif, kolaboratif, berorientasi pada mutu.
Marilah bergabung bersama Hanacaraka Training Center Indonesia untuk meningkatkan knowledge dan skill SDM kesehatan dalam meningkatkan kesehatan masyarakat dan menyukseskan Indonesia maju dan sehat.
PT Prima Medicina Hanacaraka terdepan dalam melatih tenaga kesehatan untuk membangun masa depan Indonesia yang lebih sehat. Selamat datang di PT Prima Medicina Hanacaraka, lembaga pelatihan kesehatan terkemuka yang berkomitmen untuk mencetak tenaga kesehatan profesional yang siap menjawab tantangan di masa depan. Sejak awal didirikan, kami telah berkontribusi dalam meningkatkan kualitas layanan kesehatan melalui pendidikan dan pelatihan yang berkualitas tinggi. Kami percaya bahwa masa depan kesehatan bangsa terletak pada tenaga kesehatan yang terampil dan kompeten. Oleh karena itu, misi kami adalah menyediakan pelatihan yang inovatif, berbasis praktik, dan sesuai dengan standar nasional, untuk memberdayakan para profesional kesehatan dalam memberikan layanan terbaik kepada masyarakat.
Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Hanifah, Direktur PT Prima Medicina Hanacaraka. Hanacaraka Training Center Indonesia adalah salah satu anak usaha dari PT Prima Medicina dalam bidang pelatihan dan peningkatan kompetensi SDM kesehatan yang telah terakreditasi tahun 2023 B oleh Kementerian Kesehatan dan telah terakreditasi A tahun 2024 oleh Kementerian Kesehatan dan tahun 2025 telah terverifikasi oleh Kementerian Tenaga Kerja. Alumni Hanacaraka telah menyebar di seluruh Indonesia, adalah sekitar 11.000 peserta yang menyebar seluruh Indonesia, dan lembaga institusi yang telah kerjasama dengan Hanacaraka Training Center Indonesia sekitar 70 lebih lembaga pemerintah maupun swasta, rumah sakit, puskesmas, klinik, maupun lembaga pendidikan. Komitmen kami menghadirkan layanan terbaik melalui keunggulan yang menjadi nilai tambah bagi setiap peserta dan mitra, trainer profesional, metode interaktif dan aplikatif. Hanacaraka Training Center Indonesia punya layanan Hanacaraka Care dan jejaring kerjasama, di mana Hanacaraka Care adalah alur pendampingan peserta secara menyeluruh dari awal kegiatan pelatihan hingga pasca pelatihan untuk memastikan kompetensi terrealisasi dan berdampak di tempat kerja. Jejaring kerjasama kami dengan rumah sakit dan pasienkes, dinas kesehatan, perguruan tinggi, organisasi profesi, perusahaan BUMN, BUMD, dan perusahaan maupun instansi lainnya. Komitmen kami hari ini untuk kesehatan Indonesia dan untuk peningkatan kompetensi tenaga kerja yang lebih baik untuk esok. Hanacaraka Training Center Indonesia akan terus berinovasi, memperluas kolaborasi, dan memberikan layanan pelatihan terbaik untuk mencetak tenaga kerja dan tenaga kesehatan yang kompeten, profesional, dan berdaya saing global, sehingga layanan yang diberikan untuk meningkatkan kepuasan pelanggan pasien yang diberikan layanan menjadi safety. Misi kami adalah menjadi pusat pengembangan kompetensi tenaga kesehatan dan tenaga kerja terpercaya dan terdepan di Indonesia. Misi kami menyelenggarakan pelatihan berkualitas, inovatif, relevan untuk meningkatkan kompetensi dan mutu layanan kesehatan dan tenaga kerja. Nilai kami integritas, kompeten, inovatif, kolaboratif, berorientasi pada mutu.
Marilah bergabung bersama Hanacaraka Training Center Indonesia untuk meningkatkan knowledge dan skill SDM kesehatan dalam meningkatkan kesehatan masyarakat dan menyukseskan Indonesia maju dan sehat.
PT Prima Medicina Hanacaraka, terdepan dalam melatih tenaga kesehatan untuk membangun masa depan Indonesia yang lebih sehat. Selamat datang di PT Prima Medicina Hanacaraka, lembaga pelatihan kesehatan terkemuka yang berkomitmen untuk mencetak tenaga kesehatan profesional yang siap menjawab tantangan di masa depan. Sejak awal didirikan, kami telah berkontribusi dalam meningkatkan kualitas layanan kesehatan melalui pendidikan dan pelatihan yang berkualitas tinggi. Kami percaya bahwa masa depan kesehatan bangsa terletak pada tenaga kesehatan yang terampil dan kompeten. Oleh karena itu, misi kami adalah menyediakan pelatihan yang inovatif, berbasis praktik, dan sesuai dengan standar nasional, untuk memberdayakan para profesional kesehatan dalam memberikan layanan terbaik kepada masyarakat.
Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Halifah, Direktur PT Prima Medicina Hanacaraka. Hanacaraka Training Center Indonesia adalah salah satu anak usaha dari PT Prima Medicina dalam bidang pelatihan dan peningkatan kompetensi SDM kesehatan yang telah terakreditasi tahun 2023 B oleh Kementerian Kesehatan dan telah terakreditasi A tahun 2024 oleh Kementerian Kesehatan dan tahun 2025 telah terverifikasi oleh Kementerian Tenaga Kerja. Alumni Hanacaraka telah menyebar di seluruh Indonesia
speaker, we would like to apologize as we have an additional speech from the Dean of Itekes, Ibu Nurse Maria Mecharoh, Sarjana Keperawatan Magister Kesehatan. And it's yours, Bu Maria.
Nah, oke, Ibu Tris, terdengar suara saya jelas?
Ya, clear, Bu.
Oke, baik. Oke, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Mbak Tris.
Baik, teman-teman semuanya sudah bergabung di ruang Zoom. Sudah mulai banyak ya. Semoga tetap semangat. Tadi sudah lunch ya, makan siang. Semoga tidak ngantuk karena di sesi kedua ini, sesi sore, sesi dangerous ya ini. Pak Zulkifli sudah ready sekali.
Ya Mbak,
Ya,
sudah
mohon.
siap.
Baik, kita lanjut. Let's to the third speaker. Is Bapak, saya panggil Bapak saja ya Pak, Pak Mister ini.
Dipanggil Bapak boleh, dipanggil Mister boleh.
Ya, Mr. Zulkifli Nurdin, Sarjana Keperawatan, Magister Manajemen, Magister Keperawatan from ITKS Muhammadiyah Sidrap. He will give some information regarding to transforming rural community nursing and midwifery practice. But before he is going to talk, allow me to read his curriculum vitae. Yeah, our first speaker is Mr. Zulkifli Nurdin. He holds a bachelor's and professional nursing degree from Stikes Nani Hasanuddin, Makassar, and a master's in management from at head of the quality assurance unit for nursing and nurse program. Yeah, welcome to Mr. Zulkifli Nurdin. You have 30 minutes to 45 minutes to present.
Oke, thank you Mbak Tris.
Sama-sama.
Ya, mungkin saya bisa dibantu untuk share saya punya PPT panitia. That are not only theoretical sound, but practically are aspirant-led practitioner, resectioner, educators, and can being applying in your own context. Bapak dan Ibu sekalian, ya dalam sesi ini kita akan membahas ya, mungkin saya menyambung saja dua materi sebelumnya tentang bagaimana tantangan nyata ya dalam slide saya ini kita menghadapi yang dihadapi di komunitas pedesaan ya, bagaimana kita menelusuri bagaimana model-model inovatif yang telah terbukti efektif di berbagai belahan dunia, dan kita bersama-sama bagaimana merumuskan suatu strategi yang bisa langsung kita terapkan dalam pekerjaan sehari-hari kita sebagai perawat dan sebagai bidan di layanan keperatan dan layanan kebidanan di pedesaan. Ya, izinkan saya Bapak dan Ibu untuk memulai dengan sebuah pertanyaan sederhana, ya. Kapan terakhir kali ya pasien kita harus berjalan lebih dari 2 jam hanya untuk mencapai fasilitas kesehatan terdekat, ya? Atau ketika seorang ibu hamil ya tidak mendapatkan pertolongan persalinan yang tepat karena keterbatasan akses. Nah, Bapak dan Ibu sekalian, itulah realitas yang akan kita hadapi bersama hari ini dan bagaimana kita bersama-sama akan mencari jawabannya. Ya, slide yang kedua. Ya, selama bertahun-tahun ya mungkin banyak dari kita ya kita diajari dari masalah kesehatan di pedesaan ya pada dasarnya adalah masalah jarak yang kita hadapi. Jadi pandangan tradisional menyederhanakan bahwa bagaimana persoalan ya menjadi sekedar masyarakat jauh dari rumah sakit atau jalan buruk atau medannya sulit ya seolah-olah kita membangun kalau kita membangun jalan dan klinik ya semua masalah akan selesai. Nah, slide yang kedua ini ya saya mengajak kita semua untuk bagaimana melihat di dalam realitas ya realitas modern yang menunjukkan bahwa disparitas kesehatan pedesaan itu jauh lebih kompleks dari sekedar jarak geografis ya seperti pada saat ini ya kita kadang mengeluhkan masalah jarak. Ya, pertama ya kita dihadapkan pada hambatan sosioekonomi. Itu saling berpotongan dengan kronik poverty yang membuat biaya pengobatan menjadi penghalang nyata. Ya, ditambah lagi dengan rendahnya health literasi yang membuat banyak warga tidak mengenali bagaimana gejala penyakit mereka sendiri sehingga sudah terlambat. Yang kedua, ada perubahan perilaku yang kompleks. Ya, ketika pertanian dimodernisasi dengan mesin, ya, aktivitas mesin masyarakat justru menurun drastis. Ya, jadi dengan kehadiran bantuan modernisasi mesin, justru aktivitas fisik dari masyarakat kita justru menurun drastis. Ya, jadi ketika akses makanan olahan meningkat, kemudian pola makanan tradisional sebenarnya itu lebih sehat mulai ditinggalkan. Ya, inilah disebut paradox of agricultural mechanization. Ya. Yang ketiga, ya, paradigma budaya terus berevolusi. Jadi kepercayaan lama tentang penyakit dan pengobatan bertemu dengan informasi modern. Ini tidak selalu menghasilkan yang harmoni, ya. Nah, jadi pesan kunci dari slide ini adalah bagaimana kita para praktisi sebagai garis terdepan, ya, seperti kita tidak bisa lagi hanya berbekal pada peta dan kendaraan ya, seperti yang dikeluhkan selama ini antara jarak pelayanan kesehatan mungkin jauh ya. Juga kita membutuhkan kerangka kerja yang inovatif dan bagaimana kita beradaptasi untuk menavigasi landscape multidimensional ini. Nah, jadi kita perawat, bidan, komunitas itu harus menjadi navigator sosial, bukan sekedar ya pemberian pelayanan medis pada seperti yang kita lakukan setiap harinya. Ya, Bapak dan Ibu, next slide, di slide yang ketiga. Setelah kita memahami ya bagaimana kompleksitas masalah ya, bagaimana kita sekarang fokus pada solusi. Nah, jadi webinar ini dibangun di atas 3 tujuan inti yang saling melengkapi ya seperti yang dikatakan tadi oleh pemateri sebelumnya dan pengantar ya. Saya menggambarkan sebagai 3 lingkaran yang berpotongan seperti yang kita lihat pada slide. Ya, seperti kita lihat pada slide di tujuan pertama adalah bagaimana menganalisis dari dual burdens. Bagaimana kita memahami ya mendalam bagaimana pergeseran epidemiologi yang sedang terjadi di pedesaan. Ya, jadi kita hanya menghadapi beban penyakit menular yang belum selesai, tetapi secara bersamaan juga kita menghadapi lonjakan penyakit tidak menular atau kita sebut dengan PTM ya, penyakit tidak menular seperti hipertensi ya, diabetes, penyakit kardiovaskular. Ditambah lagi dengan tantangan tumbuh kembang anak usia dini yang sering terabaikan. Ini adalah double burden yang membutuhkan strategi ganda. Nah, kemudian tujuan yang kedua adalah bagaimana mengintegrasikan antara dual solution. Jadi kita tidak bisa memilih antara teknologi digital atau pendekatan budaya. Ya, jadi kita harus menggabungkan keduanya. Nah, inovasi digital seperti telehealth, kemudian AI assistant screening, itu harus berjalan beriringan dengan pendekatan yang sangat sensitif terhadap ya nilai atau kepercayaan budaya lokal. Nah, ini yang disebut dengan high tech meet high touch ya. Jadi tujuan ketiga adalah bagaimana membangun fondasi berkelanjutan. Setiap perubahan itu yang tidak tertanam di dalam sistem lokal itu akan layu ketika proyek berakhir. Maka kita harus membangun kapasitas masyarakat sendiri. Bagaimana memperkuat kader, membangun sistem evaluasi yang kuat, kemudian bagaimana menciptakan mekanisme pembiayaan yang mandiri. Nah, jadi ketiga tujuan ini ya tidak bisa tercapai secara terpisah. Nah, irisannya ya bagian mana dari ketiga ini bertemu. Itulah zona transformasi sesungguhnya yang ingin kita capai bersama-sama dalam webinar ini. Next slide. Ya, saya ingin membayangkan Bapak dan Ibu ya, membayangkan bahwa sebuah gunung es yang terlihat di permukaan adalah pasien-pasien yang datang ke puskesmas dengan keluhan tekanan darah tinggi atau gula darah yang tidak terkontrol. Tetapi ya, kalau kita melihat fenomena gunung es, tetapi di bawah permukaan ya, bagian yang jauh lebih besar dari dan lebih berbahaya adalah bagaimana sistem resiko yang kompleks yang harus bekerja secara diam-diam di dalam komunitas kita. Nah, jadi slide ini ya memetakan apa yang saya sebut dengan arsitektur resiko PTM. Ya, dengan dua sumbu utama, ya, sumbu vertikal yang menunjukkan bahwa perilaku dan gaya hidup. Kemudian sumbu horizontalnya itu adalah menunjukkan hambatan sosioekonomi dan akses layanan. Nah, dari sisi perilaku dan gaya hidup, ya kita menyaksikan yang namanya pergeseran yang dramatis, ya. Ya, masyarakat yang dulunya mengkonsumsi pangan tradisional yang kaya serat, kini beralih ke makanan ultra proses yang tinggi, ya, seperti garam, garam berlebih, kemudian gula berlebih, kemudian ditambah lagi dengan lemak berlebih. Nah, jadi mekanisme pertanian telah mencuri aktivitas fisik dari kehidupan sehari-hari. Dan bagaimana penggunaan tembakau tradisional serta penggunaan alkohol lokal ya tetap tinggi. Nah, di sisi hambatan sistemik ya, kita menghadapi tiga tantangan serius. Yang pertama adalah rendahnya literasi kesehatan yang membuat gejala awal PTM seperti sakit kepala ringan atau sering buang air kecil itu dianggap sebagai hal biasa, Bapak dan Ibu. Ya, bukan tanda bahaya. Yang kedua adalah jarak yang harus ditempuh. Ya, hanya untuk ya screening tekanan darah atau gula darah itu menjadi hambatan yang nyata bagi masyarakat pedesaan ya, tidak punya kendaraan atau tidak memiliki waktu. Ya, kemudian yang ketiga adalah kemiskinan. Ya, jadi kemiskinan itu membuat akses ke obat-obatan itu rutin menjadi ya kemewahan yang tidak terjangkau setiap bulan. Nah, dari hasil potongan kedua kekuatan ini ya sesungguhnya mengkhawatirkan bahwa tingginya angka multimorbiditas yang tidak terdeteksi dan tidak terkelola. Pada akhirnya ya berujung pada ya pengeluaran kesehatan yang bersifat katastrofik atau memiskinkan keluarga dalam sekali rawat inap. Nah, inilah mengapa PTM disebut epidemi diam-diam. Ya, ia tidak bersuara tetapi tidak berteriak minta tolong, ya. Jadi ia bekerja perlahan di dalam tubuh seseorang sampai krisis terjadi. Dan tugas kita adalah bagaimana menghentikan ya sebelum krisis itu datang. Next slide. Transformasi kesehatan komunitas pedesaan ya tidak bisa hanya terfokus pada orang dewasa ya yang sudah sakit. Ya, kita harus mundur lebih jauh Bapak dan Ibu ya. Jauh ke awal kehidupan ya, bahkan sebelum kelahiran ya. Inilah esensi dari kerangka 1000 hari pertama ya yang kita akan bahas pada slide ini. Nah, jadi riset ilmiah ya selama 2 dekade terakhir itu menegaskan suatu fakta bahwa kondisi kesehatan seseorang di usia dewasa itu sangat ditentukan oleh apa yang terjadi dalam 270 hari kehamilan ditambah 730 hari pertama kehidupan. Nah, dari jendela waktu ini ya yang paling kritis dan paling menentukan sebenarnya. Nah, jadi slide ini menggambarkan bahwa 2 jalur determinan ya, di bagian atas adalah determinan distal, adalah faktor lingkungan yang membentuk konteks kehidupan seorang ibu ya. Termasuk pernikahan dini yang membatasi kesiapan fisik, kemudian kesiapan psikologis, kemudian rendahnya pendidikan ibu yang berhubungan langsung dengan kualitas pengasuhan dan ketidakamanan ya pangan rumah tangga itu juga mengancam asupan gizi sejak dalam kandungan. Nah, kita lihat di bagian bawah adalah determinan proksimal ya. Ya, dampak langsung yang dialami anak ya, yaitu malnutrisi ibu selama kehamilan. Jadi pemberian makanan pendamping ASI yang tidak seimbang itu kemudian infeksi berulang akibat sanitasi buruk dan keterbatasan fasilitas sanitasi yang memadai. Nah, di 2 jalur yang bermuara pada 2 cabang yang sangat berbeda. Nah, cabang pertama adalah stunting fisik ya, yang kita sudah kenal baik ya, disertai dengan peningkatan risiko penyakit tidak menular pada masa dewasa. Nah, kemudian kita lihat cabang yang kedua yang lebih tersembunyi dan sering diabaikan adalah developmental neglect. Anak yang melewatkan tonggak perkembangan kognitif ya, bahasa, kemudian motorik, kemudian sosial emosional ya, karena tidak ada sistem deteksi dini yang berfungsi. Nah, bagi para bidan di ruang Zoom ini ya, pesan ini sangat penting ya. Setiap kunjungan antenatal ya, setiap konseling laktasi, setiap sesi edukasi gizi itu adalah investasi masa depan yang dampaknya akan terasa 20 tahun ke depan. Dan bagi teman-teman perawat komunitas ya, program posyandu yang kita kelola itu bukan sekedar rutinitas menimbang berat badan. Itu adalah garis pertahanan pertama bagaimana melawan krisis ganda yang sedang kita hadapi Bapak dan Ibu. Slide berikutnya. Nah, kita memasuki dimensi yang kedua dari pendekatan transformasi kita Bapak dan Ibu ya, bagaimana teknologi digital itu dapat menjembatani kesenjangan kesehatan antara kota dan desa ya. Jadi kita sering menampilkan apa yang saya sebut sebagai ekosistem kesehatan digital pedesaan. Nah, jadi 3 pilar teknologi yang saling terhubung ya. Untuk pilar pertama adalah telehealth dan mHealth. Ya, kita bayangkan seorang ibu hamil di desa terpencil yang dapat mengikuti kelas prenatal melalui smartphone-nya. Ya, bagaimana memantau tekanan darahnya dengan aplikasi dan bagaimana berkonsultasi langsung dengan bidan tanpa harus menempuh jarak perjalanan yang berjam-jam ya. Seperti saya katakan di awal tadi ya, bahwa jarak itu selalu dikeluhkan, ya apalagi kalau masyarakat pedesaan, ya. Nah ini apalagi namanya di aplikasi ya, tentunya kita sesuaikan dengan bahasa lokal ya yang dirancang khusus untuk bagaimana komunitas ya meningkatkan kepatuhan perawatan secara signifikan. Ya, karena informasi yang disampaikan dalam bahasa-bahasa yang benar dipahami, ya disederhanakan ya. Nah, kemudian pilar yang kedua adalah AI assistant screening. Nah, disinilah kita benar-benar bagaimana mengubah ya permainan perawat ya di daerah terpencil ya kini bisa menggunakan mekanis learning melalui tablet misalnya ya. Ya, bagaimana memprediksi resiko kardiovaskuler pasien ya. Kemudian tanpa peralatan laboratorium yang canggih misalnya. Nah, kemudian pilar yang ketiga adalah bagaimana digital record system. Ya, kita bayangkan ya pos-pos kesehatan di desa yang selama ini yang dikelola ya dari catatan pasien yang dalam berbentuk buku ya dicatat. Kini menggunakan sistem pelacakan elektronik ya yang terintegrasi. Ya, dengan mungkin disertai dengan pengingat otomatis untuk imunisasi misalnya, kemudian jadwal kunjungan, kemudian bagaimana peningkatan ketika pasien tidak hadir ya, kemudian informasi yang dulu terputus antara fasilitas kini bisa diakses secara real time. Nah, jadi ketiga pilar ini tidak bekerja secara terpisah ya, mereka membentuk suatu jaringan yang saling memperkuat dan di sini kita ingin menegaskan bahwa sesuatu yang sangat penting. Teknologi ini bukan untuk menggantikan perawat atau bidan. Ia adalah alat untuk bagaimana memperkuat dan melipat gandakan dampak dari kita, dari sentuhan manusia, ya touch, ya kemudian empati, kemudian kepercayaan. Nah, itu dibangun antara tenaga kesehatan dengan komunitas. Ya, itu bisa digitalisasi. Nah, kemudian slide selanjutnya Bapak dan Ibu ya, sekarang kita tiba di salah satu bagian yang paling dekat dengan hati kita semua ya. Ya, saya yakin ya bagi banyak dari kita ya yang bekerja secara langsung di lapangan ya kita berbicara tentang budaya. Karena tanpa kepekaan budaya, ya, semua teknologi canggih dan protokol medis terbaik sekalipun itu tidak akan berhasil. Nah, jadi slide ini menggambarkan 4 komponen kunci dari cultural sensitive care, ya, yang saya ilustrasikan dengan sebagai cahaya matahari yang menerangi semua aspek pelayanan kita. Nah, jadi komponen pertama adalah cultural awareness and knowledge. Ini dimulai dari dalam diri kita sendiri ya, bagaimana menganalisis bias sistemik yang tidak kita sadari ya, sambil secara aktif mempelajari pandangan dunia lokal dan praktik penyembuhan tradisional yang dipegang oleh komunitas kita. Nah, penting untuk dipahami bagaimana pengetahuan budaya bukan tentang bagaimana menghafal fakta-fakta tentang suatu suku ya, ia tentang bagaimana rasa hormat dan tulus dan keinginan yang otentik. Nah, kemudian komponen yang kedua adalah cultural encoders. Ya, jadi slide ini mencontohkan bagaimana penggunaan dialek lokal dan alat bantu visual yang dikontekstualisasikan secara budaya untuk bagaimana melampaui hambatan literasi kesehatan. Nah, kita bayangkan suatu perbedaan ya, dampaknya ketika kita menjelaskan diabetes kepada seorang nenek di pedesaan menggunakan bahasa daerah dan gambar yang akrab dibandingkan kalau kita memperlihatkan misalnya leaflet medis formal dalam bahasa Indonesia yang kaku, ya kan? Nah, jadi disinilah peran dari cultural contrast. Nah, kemudian komponen yang ketiga adalah strategic integration. Ya, kemudian bermitra langsung ya mungkin dengan tokoh-tokoh adat lokal, tokoh adat, kemudian pemimpin lokal. Ya, bagaimana untuk membangun kepercayaan otentik. Ya, di banyak komunitas pedesaan, ya, kepercayaan kepada tenaga kesehatan itu harus diperoleh melalui kepercayaan ya dari tokoh-tokoh yang sudah dikenal di komunitas. Nah, jadi ini kolaborasi ya, bukan kompetisi. Jadi kolaborasi bukan kompetisi. Ini adalah kunci dari komponen yang ketiga ini. Kemudian komponen yang keempat adalah care adaptation. Care adaptation ini mengintegrasikan antara pangan lokal yang bergizi tinggi ke dalam konseling nutrisi berbasis bukti seperti yang dijelaskan oleh pemateri-pemateri sebelumnya ya, bahwa alih-alih merekomendasikan makanan yang tidak tersedia atau tidak terjangkau, kita bekerja dengan apa yang sudah ada ya, misalnya sudah tersedia tempe, kemudian ikan kering, kemudian sayur lokal ya, bagaimana kita menunjukkan bagaimana bahan-bahan ini memenuhi kebutuhan gizi yang kita targetkan. Jadi perlu diingat bahwa high touch tanpa high touch adalah otomasi tanpa empati. Ya, jadi high touch tanpa high touch itu adalah kasih sayang tanpa efisiensi. Ya, jadi kita membutuhkan keduanya dalam proporsi yang tepat untuk setiap komunitas yang kita layani, Bapak dan Ibu. Nah, kemudian slide selanjutnya, ya, slide yang ke-8 ya. Ya, kita sudah membahas apa yang perlu dilakukan dan bagaimana melakukannya. Ya, sekarang pertanyaan terpenting bagaimana kita memastikan semua ini ya bertahan lama ya. Sejauh mana proyek ini berakhir ya, jauh setelah kita tidak lagi hadir di lapangan. Nah, jadi slide ini menggambarkan bahwa ya, slide ini menggambarkan bahwa slide ke-8 Bapak Ibu. Slide sebelumnya. Ya, kita sudah membahas apa yang perlu dilakukan dan bagaimana melakukannya ya. Sekarang pertanyaan terpenting bagaimana kita memastikan semua ini bertahan lama ya. Nah, jadi slide ini ya menampilkan apa yang disebut arsitektur berkelanjutan ya. Ya, sebuah bangunan dengan 3 pilar yang kokoh dan 1 bangunan kunci yang menahan semuanya. Nah, jadi kita lihat pilar kiri itu adalah agriculture and food security ya. Nah, kesehatan tidak bisa terpisahkan dari ketahanan pangan. Nah, jadi intervensi kesehatan di berkelanjutan itu harus berjalan seiring dengan upaya mengamankan keanekaragaman pangan lokal ya, ketika seluruh keluarga memiliki akses konsisten terhadap pangan bergizi. Nah, kemudian fondasi kesehatan mereka ya menjadi lebih kuat juga. Kemudian kita lihat pilar yang tengah adalah education and social protection ya. Nah, bagaimana mengingatkan tentang literasi kesehatan, bukan hanya tentang bagaimana membagikan leaflet ya. Dia tentang bagaimana membangun kapasitas keluarga untuk bagaimana melindungi diri mereka lintas generasi. Nah, jadi program perlindungan keluarga yang terintegrasi dengan edukasi kesehatan itu menciptakan efek pengganda yang luar biasa. Nah, jadi kita lihat ya, kalau pilar yang kanan itu adalah infrastruktur, itu memperkuat akses terhadap bagaimana sanitasi air bersih misalnya. Ya, kita tidak bisa berbicara tentang bagaimana pencegahan penyakit sementara anak-anak itu masih buang air sembarangan tempat dan keluarga itu masih minum air yang tidak aman. Nah, kalau kita lihat yang di puncak, yang di kuning itu Bapak dan Ibu ya, ya bagaimana dia menahan ketiga pilar ini. Ini adalah batu kunci community cadres ya. Jadi kader kesehatan komunitas. Mereka ini yang menjaga bagaimana keberlanjutan ya, kemudian dengan melatih ya, memberdayakan kader lokal ya untuk bagaimana memberikan intervensi yang terus-menerus dan terlokalisasi. Ya, jadi kita menciptakan sistem yang tidak tergantung pada kehadiran tenaga kesehatan dari luar setiap saat. Nah, jadi kalau kita lihat fondasi dari seluruh bangunan ini adalah kebijakan. Konkretnya adalah bagaimana mengintegrasikan prioritas kesehatan ke dalam tata kelola desa dan mewajibkan pembiayaan preventif yang terdesentralisasi ya ke level desa ya, ketika kesehatan masuk ke dalam ya musyawarah desa, kemudian kesehatan masuk ke dana desa ya, ini adalah keberlanjutan ya, bukan lagi ya menjadi suatu impian saja ya, tetapi ini adalah bagian dari menjadi suatu sistem. Kemudian slide selanjutnya Bapak dan Ibu ya. Jadi seluruh sistem yang telah kita bangun di dalam presentasi ini ya, model inovatif, kemudian teknologi digital, kemudian pendekatan budaya, kemudian arsitektur berkelanjutan, ini semua bertumpu pada suatu faktor yang paling kritis ya. Jadi para praktisi sebagai garis terdepan ya, perawat, kemudian bidan yang setiap hari turun ke lapangan ya, kemudian menghadapi realitas yang kompleks ya dengan sumber daya yang terbatas. Nah, jadi slide ini menggambarkan bagaimana tujuan dari transformasi kita untuk para praktisi menggunakan simbol infinity ya. Sebuah perjalanan yang tidak pernah berhenti berkembang. Nah, dari sisi kiri adalah evidence based practice ya, jadi praktik berbasis bukti ya, bukan sekedar mengikuti protokol dari buku teks yang mungkin ditulis di konteks yang sangat berbeda. Ya, tentang bagaimana memadukan ya 3 hal sekaligus ya, bukti penelitian terbaik yang tersedia, kemudian keahlian klinis yang Anda kembangkan dari pengalaman bertahun-tahun, kemudian nilai-nilai komunitas yang Anda layani. Lebih dari itu ya, pendekatan ini tentunya mendorong kita untuk menjadi local action research. Ya, jadi praktisi yang tidak hanya menggunakan pengetahuan, tetapi juga dia menghasilkan pengetahuan dari lapangan kita sendiri. Nah, kita lihat di sisi kanan adalah blended capacity building ya. Kita harus melampaui model pelatihan terpusat yang konvensional, di mana peserta-peserta datang ke kota, kemudian duduk mendengarkan, lalu kembali ke lapangan dengan sedikit perubahan nyata. Ya, jadi model yang lebih efektif dari menggabungkan monitoring virtual yang berkelanjutan, ya seperti modul e-learning mandiri. Itu bisa diakses kapan saja, kemudian dengan simulasi klinis langsung yang terlokalisasi, kemudian menggunakan skenario dari komunitas nyata yang kita hadapi. Nah, kemudian di tengah titik persilangan ya, simbol infinity adalah tujuan bagaimana mengubah perawat dan bidan di pedesaan dari sekedar penyedia perawatan dasar ya, jadi pemimpin kesehatan yang otonom dan arsitek dari sistem. Bukan hanya mengobati penyakit, tetapi bagaimana kita merancang suatu sistem yang mencegahnya. Ya, nah ini bukan ambisi Bapak dan Ibu ya, ambisi yang terlalu tinggi. Ini adalah standar yang komunitas pedesaan berhak untuk bagaimana mendapatkannya. Dan kita ini, kemudian dukungan yang tepat, tentu kita memiliki keinginan bagaimana kita mampu mencapainya bersama. Kemudian slide selanjutnya Bapak dan Ibu. Ya, tidak ada transformasi yang lengkap tanpa bagaimana evaluasi yang sistematis. Ya, jadi slide ini memperkenalkan bahwa model logik evaluasi yang menghubungkan setiap komponen intervensi yang kita berikan, ya, kemudian proses implementasi hingga dampak jangka panjangnya bagaimana dalam sebuah rantai yang koheren dan terukur, ya. Nah, kemudian tahap pertama adalah proses. Disinilah implementasi yang terjadi. Ya, jadi bagaimana penerapan alat-alat digital yang diadaptasi secara budaya. Kemudian modul pembelajaran campuran sesuai konteks, kemudian pelatihan kader yang aktif dan berkesinambungan. Nah, jadi proses yang baik adalah prasyarat untuk semua yang berikutnya, ya. Nah, ini yang paling mudah diukur, ya. Nah, namun paling sering ya diabaikan dalam evaluasi. Kemudian tahap yang kedua adalah output, ya. Ya, output itu adalah hasil langsung yang didapat, ya, kita hitung dan dokumentasikan. Ya, jadi peningkatan cakupan screening primer, ya. Jadi peningkatan literasi kesehatan komunitas yang terukur. Kemudian terbentuknya kemitraan lintas sektor yang terformalisasi, kemudian output adalah bukti bahwa proses kita benar-benar berjalan ya, bukan sekedar ya aktivitas atau aktivitas yang di atas kertas ya. Nah, kemudian tahap yang ketiga adalah outcome ya. Jadi outcome ini merupakan perubahan perilaku ya dari kondisi yang terjadi sebagai hasil dari output kita. Nah, jadi kepatuhan pengobatan yang meningkat secara berkelanjutan ya, kemudian pemantauan tumbuh kembang anak yang aktif dan terukur, kemudian rutinitas perawatan preventif yang sudah terinternalisasi ya dalam kehidupan masyarakat. Kemudian tahap yang keempat adalah ini yang paling penting juga adalah dampak jangka panjangnya, bagaimana pengurangan beban PTM yang berkelanjutan. Nah, kemudian lintasan tumbuh kembang anak ya usia dini yang optimal ya, ini adalah alasan ya mengapa kita melakukan semua hal tersebut ya. Jadi model logik ini bukan hanya alat evaluasi untuk peneliti, ia adalah peta jalan ya bagi setiap program kesehatan komunitas. Bagaimana memastikan setiap aktivitas yang kita lakukan terhubung langsung dengan dampak yang ingin kita capai ya. Jadi ketika kita bisa menunjukkan rantai sebab akibat ya kepada pembuat kebijakan dan pemangku kepentingan, kita juga membangun argumen yang kuat untuk investasi berkelanjutan dan di dalam keperawatan komunitas. Nah, di slide selanjutnya. Nah, jadi transformasi kesehatan komunitas masyarakat pedesaan ya. Ini bukan merupakan pekerjaan satu pihak ya. Dia adalah tanggung jawab bersama dari seluruh ekosistem. Ya, baik itu pemerintah, kemudian akademisi, kemudian profesional kesehatan. Ya, jadi slide ini menyajikan matriks akuntabilitas yang mendefinisikan dengan jelas bagaimana peran dan kontribusi spesifik dari setiap aktor yang saya sebutkan tadi. Dari sisi pemerintah dan kebijakan, 3 agenda mendesak harus diprioritaskan. Yang pertama adalah bagaimana membangun regulasi telehealth yang kuat, bukan untuk membatasi ya, tetapi untuk melindungi ya, bagaimana memfasilitasi praktik yang aman dan efektif. Kemudian yang kedua adalah bagaimana mewajibkan pembiayaan preventif yang terdesentralisasi ya di tingkat desa. Ya, karena kesehatan harus masuk dalam anggaran dana desa ya, bukan hanya jadi program titipan dari atas ya. Kemudian ketiga, mempercepat perluasan infrastruktur kesehatan digital. Karena konektivitas internet dan listrik yang handal adalah, nah ini salah satu persyaratan dari semua inovasi digital yang kita bahas tadi. Nah, kemudian dari sisi akademisi dan pendidikan, ada 4 tanggung jawab besar ya. Nah, yang pertama adalah bagaimana mengintegrasikan kesehatan digital dan antropologi budaya ya ke dalam ya kurikulum inti keperawatan dan kebidanan ya, bukan sebagai mata kuliah pilihan ya, tetapi sebagai kompetensi wajib ya. Bagaimana mendukung penelitian translasional ya, yang menjembatani bahwa laboratorium dan lapangan ya. Kemudian mewajibkan residensi komunitas pedesaan sebagai bagian dari pendidikan ya. Nah, kemudian yang terakhir Bapak dan Ibu ya. Ya, slide yang terakhir ya. Nah, kita sudah banyak membahas tentang slide-slide sebelumnya ya. Dari itu bagaimana kita memahami kompleksitas dari kesehatan yang ada di pedesaan. Mari kita menelusuri ya, inovasi model keperawatan komunitas, bagaimana mengeksplorasi ekosistem digital kesehatan dan bagaimana kita merumuskan matris akuntabilitas bersama. Kita kembali ke sebuah kebenaran yang sederhana namun sangat kuat Bapak dan Ibu. Ya, para praktisi garis depan bukan sekadar pemberi perawatan. Mereka adalah arsitek kesetaraan kesehatan. Ya, jadi saya ingin mengakhiri ya dengan mengajak kita semua bagaimana merefleksikan kalimat ini dalam konteks pekerjaan kita semua. dalam kehidupan sehari-hari. Setiap kunjungan rumah yang kita lakukan, ya, setiap konseling yang Anda berikan, setiap kadar yang Anda latih, setiap data yang Anda dokumentasikan, semua itu adalah bata-bata yang membangun sistem kesehatan yang lebih adil dan merata. Anda mungkin tidak selalu melihat dampaknya secara langsung, tetapi perubahan perilaku itu membutuhkan waktu. Kepercayaan komunitas dibangun perlahan. Kebijakan berubah lambat, tetapi sejarah telah membuktikan bahwa transformasi besar selalu dimulai dari individu-individu yang berani bekerja di garis paling depan. Ya, tentunya dengan penuh keyakinan bahwa tindakan kecil itu sangat bermakna. Ya, satu hal yang saya minta dari kita semua adalah sebelum kita mengakhiri webinar ini, ya, kita tuliskan satu komitmen yang konkret yang kita lakukan, ya, selama ya mungkin 30 hari ke depan, ya. Ya, mungkin bukan rencana besar, ya, cukup satu langkah kecil saja yang nyata, ya. Nah, karena kita yakini bahwa 1000 langkah perjalanan itu selalu dimulai dari langkah-langkah pertama. Ya, terima kasih Bapak dan Ibu, ya, atas perhatian. Jadilah arsitek, ya, bukan hanya penyedia kesehatan, ya, untuk komunitas yang Anda cintai, ya. Ya, itu saja mungkin Bapak dan Ibu saya sampaikan, ya. Mungkin ada beberapa contoh, ya, praktik baik yang dilakukan teman-teman di ITKES, ya, mungkin ini sambil sosialisasi, ya, mungkin Bapak dan Ibu, ya, mungkin bisa di close dulu slide-nya. Dilakukan teman-teman yang ada di ITKES Muhammadiyah Sidrap, ya. Ini aplikasi bagaimana gerakan kaki sehat, kemudian sirkulasi lancar, ya. Kemudian ini adalah beberapa program latihan online, ya, untuk mengatasi gejala diabetes, ya, neuropati, ya. Ini adalah solusi digital bagaimana pencegahan edukasi neuropati perifer. Kemudian program ini dikembangkan dalam bentuk platform, ya, berbasis website sehingga bisa diakses secara luas, ya, mudah, kemudian mandiri oleh penderita diabetes maupun masyarakat umum yang ingin mencegah risiko neuropati perifer, ya. Mungkin Ibu Sri Sakinah hadir juga, ya, di dalam Zoom ini. Nah, kemudian tujuan utama, ya, bagaimana peningkatan fungsi kaki, ya, kemudian perbaikan sirkulasi darah, kemudian reduksi gejala neuropati, ya, semua ini bisa diakses, ya, dalam platform, ya, Kinaku ID, ya. Ini juga lengkap dengan latihan otot pergelangan kaki, ya, dipandu dengan apalagi namanya video edukasi, ya. Nah, ini salah satu bentuk praktik baik yang dilakukan, yang dikembangkan oleh teman-teman yang ada di ITKES Muhammadiyah Sidrap, ya. Ini bisa dipergunakan untuk umum, dan ini yang terbaru lagi, ya, dari Ibu Wakil Dekan ini, ya, ada aplikasi Sipaka Lebih, ya. Nah, ini bisa diunduh, ya, di mana itu, Bu? Diunduh di Play Store, ya. Bisa diunduh di Play Store, ya. Nah, aplikasi ini adalah sistem informasi bagaimana aduan kekerasan untuk layanan edukasi, dan bantuan intervensi psikologis, ya. Ini bisa diunduh, ya. Nah, di sini lengkap fitur-fiturnya Bapak dan Ibu, ya. Ini bisa diunduh di Android Bapak Ibu, Nah, kemudian juga lengkap dengan modul-modul di dalamnya. Nah, ini beberapa aplikasi yang dikembangkan oleh teman-temannya di KES ya melalui webinar ini ya mungkin. Nah, ini sekaligus sosialisasi mungkin Bu ya untuk memperkenalkan ke masyarakat banyak ya. Nah, mungkin itu saja moderator ya, lebih dan kurangnya mohon dimaafkan. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Luar biasa materi dari Pak. Thanks a lot, Mr. Zulkifli. Tapi masih waiting for the questions ya, nanti di forum discussion. Yeah, let's do the last speaker is Bidan Nurjana, SSTMK. She will present the topic about the first 1,000 days of life, building a strong. And midwifery educations. Okay, our time is yours, Ibu Bidan Nurjana.
Okay, thank you, Miss Tris.
Welcome.
Yeah. I will try in speak English.
Okay, very good, Bu Bidan.
Yeah. Okay. Thank you, Miss Tris. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, good afternoon, everyone. Yeah, it is a great honor to be here today and to have opportunity to share my presentation. Thank you for Hana Caraka because for Hana Caraka for inviting me to this international seminar. Today I will present a topic entitled the first 1,000 days of lifespan to support optimal growth and development in children. The first 1,000 days is not new issue. The first 1,000 days of life from conception until child's second birthday are critical period that shapes lifelong health, growth and development. During this time, proper nutrition, quality healthcare, responsive care given, and early stimulation are essential to ensure that every child reaches their full potential. I hope this presentation will provide valuable insight and knowledge. Yeah.
Ya, di laporan.
Yeah. Excuse me, can you?
Bisa dibantu mute, Mbak Nabila?
Okay. Okay, now I would like to begin my presentation. Okay. Okay, the first 1,000 days of life to support optimal growth and development in children. Okay, maybe maybe I can mix in Indonesian, Miss Tris.
Yeah, It's okay, Bu Nurjana. Yeah,
Okay.
in
Yeah.
English.
Yes. The first 1,000 days of life, the most critical window for a healthy future. The first 1,000 days of life from conception to child's second birthday is unique window of opportunity. So nutrition, care, and healthy environment during this period shape child growth, brain development, immunity, and future potential. What are the first 1,000 days of life? Yeah. Will be start in pregnancy, 270 days, plus year one is 365 days, and then 2 years, 365 days. Yeah. The first 1,000 days of life, why it's matter? Yeah, why it's matter? Because can be support brain development, promotes healthy growth, strength immunity, reduce rise of chronic disease, improve learning and potential, and the last build a better future. Okay, the first 100 days of life. What is the first 100 days of life? Yeah. The first 100 days of life refer to critical period from conception until a child reaches 2 years of age. During the first 100 days, adequate nutrition is essential to ensure optimal growth and development. Proper maternal nutrition during pregnancy, followed by appropriate infant and young child feeding practice, support healthy physical development, cognitive function, and overall well-being. This period also provides a unique opportunity to prevent malnutrition and promote healthy development throughout the life course. Is the first 1,000 days of life important? Yes, very important. You can call the golden period. Very rapid brain growth occurs during this period. Inadequate nutrition during the golden period cannot be file reserved later in life, affect their future by one, impaired physical growth, two, delayed speech development, three, delayed motor development, and the last, poor concentration, reduced intelligence. Next, a key factor for successful child development. Modern genes environment shapes their future. And key external factor, one, maternal nutrition and nutritional status during pregnancy. Two, exclusive breastfeeding until 6 months of life. Three, appropriate complementary feeding begin at 6 months of age. And four, prevention and management childhood illness. And the last, early simulation and supportive environment. Good nutrition from the beginning optimize child development. Adequate nutrition from the early stage of life plays a vital role in optimizing a child growth and development, while reducing the rise of degenerative disease later in adulthood. The first 1,000 days of life represent a critical window to opportunity for ensuring optimal physical growth, brain development, and lifelong health. Okay, what shall be done? Start in preconception period. Yeah. The following are various preparation that woman can do before pregnancy. Adopt healthy lifestyle. such as avoid exposure to pollution, avoid alcohol consumption, avoid exposure to cigarette smoke. And then eat a balanced diet with folic acid and iron supplement. Engage in moderate physical activity for at least 150 minutes every week. Maintain a normal body weight and avoid overweight and obesity. And then have regular health checkup. You can inform your medical history to the doctor, seek consultation if you have psychological issue, and get a medical checkup if you any health problem. Oke, ini beberapa contoh ya, contoh nutrisi yang sangat diperlukan pada masa sebelum hamil atau prakonsepsi. Contohnya zat besi ya. Iron ini bisa didapat dari daging, ayam, ikan, kemudian hewan laut. Kemudian selanjutnya sumber kalsium bisa dari susu, yogurt, ya, keju, olahan susu lainnya. Kemudian vitamin D bisa didapat dari telur, kemudian makanan fortifikasi, minyak ikan, dan sebagainya. Kemudian vitamin B12 bisa didapat dari ayam, chicken, daging, meat, fish, dan egg. Kemudian asam folat ini sangat penting terutama sebelum masa prakonsepsi. Ini sangat membantu untuk proses organogenesis atau pembentukan janin ya. Di antaranya hati ya, hati ayam, hati sapi, kemudian sayuran hijau, kemudian kacang-kacangan ya. Kemudian iodin ini bisa didapat dari rumput laut, makanan laut, kemudian zinc ya, zinc. Oke. Recommended for minimum antenatal care ya. For antenatal care, total minimum antenatal care visit at least 6 times ya. Not 4 times but 6 times. The nutritional status of pregnant woman not only affect the health of mother but also that of the fetus. Adequate intake of nutrition before conception help optimal growth, support metabolic process, immune response, brain development, and organogenesis, leading to better outcomes. Okay. Nutrition during pregnancy, signs the beginning of pregnancy. One, various food from all food group, and 2 iron tablet, at least 180 tablet, not 90 tablet, but 180 tablet. Prenatal check-up at least 6 times, and pregnant woman class. Okay, pregnancy process not allowed. Don't consume soft drink, don't consume alcohol, don't smoke, don't consume instant noodles, and don't take any medication without advice. Nutrition during pregnancy. WHO and FIGO recommended taking micronutrition supplements such as iron, folic acid, and calcium during pregnancy. Pregnant women are also advised to consume a variety of food to meet the needs of other micronutrition such as vitamin and mineral. Supplementation should be given. One, only when a micronutrition deficiency is found. Two, practically if the daily menu of pregnant woman is varied and balanced in both quantity and proportion. And the last, generally meets the nutritional need. Recommended macro and micronutrition for pregnant women, calcium, vitamin B12, vitamin A, vitamin D, vitamin B6, iodin, selenium, zinc, kolin, biotin, dan kapur. Nah, ini beberapa makro dan mikronutrisi yang diperlukan oleh wanita, oleh seorang ibu pada masa kehamilan. Oke. Organ development in fetus during pregnancy. Ya, jadi makro dan mikronutrisi yang tadi saya sebutkan ini sangat penting dalam pembentukan organogenesis pada fetus. Each fetal organ has a critical period of development that is different. If there are nutritional problems during this critical period, organ development can be disrupted. And even cause congenital defect. For example, lack of folic acid during the first trimester, trimester pertama, can cause disorder of the central nervous system. Okay. Childbirth process until the baby is 6 months old. One, childbirth should be attained by trained midwife or doctor. Two, early initiation of breastfeeding atau IMD, inisiasi menyusui dini, segera setelah bayi lahir. Continue to provide exclusive breastfeeding for the first 6 months. Dilanjutkan dengan pemberian ASI eksklusif selama 6 bulan, hanya ASI saja. And then regularly monitor your baby growth and development, memantau perkembangan bayi, pertumbuhan dan perkembangan bayi di posyandu. Dan yang terakhir, the last, ensure your baby receive immunization as recommended, Jadi memberikan imunisasi lengkap, sesuai dengan rekomendasi IDAI. Oke. Pada proses kelahiran, childbirth, normal pregnancy period and normal abnormal newborn cyst. Setelah 37 sampai 42 minggu kehamilan, bayi akan siap untuk dilahirkan. Jadi berat badan lahir normal, antara 2.500 sampai 4.000 gram. Kemudian untuk panjang badan, pada laki-laki itu sekitar 46,1 cm. Kemudian pada perempuan itu sekitar 45,4 cm. Kemudian pada bayi yang lahir yang panjang badannya kurang dari 48 cm, ini harus membutuhkan perhatian khusus, supaya di 1000 hari pertama kehidupan ini betul-betul nutrisinya, kemudian stimulasinya itu harus betul-betul diperhatikan supaya nantinya bayi yang lahir dengan panjang badan kurang dari 48 cm ini tidak keluar sebagai balita stunting. Oke. And next, after childbirth until 2 years. The postnatal period up to the age of 2 years is considered a critical window for establishing a child health and development. This foundation period involves growth, maturation, and ongoing development of the brain, as well as support through breastfeeding, adequate nutrition, and cognitive stimulation, all of which are extremely important. Okay. Infant 6 months to 2 years, very important to nutrition, breastfeeding and complementary food, give vitamin A capsule every 6 months, and provide complete immunization. And next, physical growth. Physical growth. During the first year, a child body length increase most rapidly, about 25 cm. This growth slows down in the second year to about half of the first year. Growth increase again during adolescence. Typically, a child length in 1.5 times date birth length at 1 year old and 2 times at 2 years old. Optimal physical growth in the first 2 years build a strong foundation for lifelong health and development. Okay. And next, during the first month after birth, a baby weight increased by about 30 grams per day. After that, weight gain slow to about 20 grams per day until the child reaches 6 months of age. This gain continue to slow gradually as the child grows older. Typically, a child weight reaches 2 times the body weight at 3 until 4 months, 3 times at 1 year, and 4 times at 2 years of age. Next, age 0 until 6 months. Infants have a different nutritional need compared to adults. Babies under 6 months don't need additional food other than breast milk. Ya, jadi bayi pada usia di bawah 6 bulan itu tidak memerlukan nutrisi apa-apa selain ASI. Ya, ini sesuai dengan rekomendasi WHO bahwa ASI eksklusif itu diberikan sampai bayi berumur atau berusia 6 bulan. Kemudian dilanjutkan dengan menyusui sampai bayi berusia 2 tahun. Kenapa ASI ini sangat penting ya? Because breast milk is the best food. Ya, jadi ASI adalah makanan terbaik. Breast milk is the best food for optimal growth and development during the first 6 months of life. Ya, jadi ASI adalah makanan terbaik untuk mengoptimalkan pertumbuhan dan perkembangan bayi sampai usia 6 bulan. It contains all essential nutrition and antibody that infant need. Ya, jadi ASI ini mengandung nutrisi esensial dan antibodi yang sangat diperlukan untuk bayi. And then early initiation is important. Yeah, early initiation of breastfeeding within the first 30 minutes after birth is highly recommended to achieve successful breastfeeding. Ya, jadi 30 menit ya. Paling lambat 30 menit sebelum setelah bayi lahir itu sudah harus diperkenalkan dengan ASI. Oke. And next, age 6 until 12 months. Yeah. After 6 months, breast milk alone is not enough to meet your baby nutritional needs for optimal growth and development. Continue breastfeeding along with appropriate complementary food. Ya, jadi setelah 6 bulan itu kebutuhan bayi akan ASI itu sudah tidak mencukupi lagi, sehingga untuk memenuhi kebutuhan nutrisinya diperlukan makanan pendamping ASI. Ya, jadi mengapa kita perlu memperkenalkan makanan pendamping ASI? Ya, why introduce complementary food? As your baby grows, their energy needs increase. Ya, jadi semakin bertambah umurnya bayi, kebutuhan energinya semakin meningkat ya. Along with their activity level and body size. Complementary food provide essential nutrition that support healthy growth and development. Ya. And next, MPASI or complementary feeding, according to the EDA, complementary feeding is recommended as follows. 6 until 8 months, about 30%. Ya, usia 6 sampai 8 bulan itu memenuhi kebutuhan sekitar 30%. Ya. Kemudian usia 9 sampai 11 bulan itu sekitar 50%, kemudian usia 12 sampai 24 bulan itu sekitar 70%. Oke. Good nutrition, good nutrition. This is nutritional adequacy rates for children, good nutrition for healthy growth, proper development, and brighter future for our children, to support optimal growth, enhance development, strengthen immunity, and promote overall health. And next, age 1 until 2 years. Jadi pada usia 1 sampai 2 tahun, mungkin kita biasa mendengar slogan isi piringku, ya. Jadi kebutuhan bayi bisa kita lihat pada isi piringku, ya. Jadi kebutuhan hampir 50% dari bayi itu berasal dari buah dan sayuran. Kemudian kebutuhan protein hewani, ya, kemudian protein nabati, ya. Ini bisa kita lihat pada isi piringku. A balanced diet with adequate energy and nutrition support optimal growth, strength immunity, and help children reach their full potential. Okay, this is example to growth trend assessment for your baby. It can be monitoring, help ensure early detection of growth problem, and support optimal growth and development. And then immunization. Immunization can be protect your child, build a healthy future. Immunization is one of most effective ways to prevent malnutrition caused by infection. Jadi imunisasi ini merupakan salah satu cara yang efektif untuk mencegah in the womb. In addition, lack of the stimulation will affect the child brain development afterward. To the impact, this problem can lead to the reduced cognitive abilities and intelligence. Reduced intelligence will affect lower academic achievement, lower earning potential in the future, and ultimately lead to lower income and welfare. Long and short-term consequences if nutritional problem during the first 1,000 days. One, maternal risk factor. Low pregnancy, biasa kita kenal dengan nama cake, cake. Kemudian yang kedua, inadequate weight gain during pregnancy, kenaikan berat badan yang tidak adekuat, ini juga berpengaruh pada fetus, kemudian bisa menyebabkan undernutrition pada fetus atau kita sebut dengan nama IUGR, kemudian intrauterine growth retardation. Kemudian selanjutnya ada impaired brain development, kemudian cognitive impairment, mental health problem, and reduced educational achievement. Undernutrition in children. Undernutrition or wasting or severely undernutrition, severely wasting is an acute from malnutrition based on low weight for height or height for age. Jadi untuk menentukan apakah dia stunting atau sangat stunting, yang menjadi patokan kita sesuai dengan standar antropometri ya, Permenkes nomor 2 tahun 2020 yang kita gunakan adalah dengan tinggi badan per umur. Kemudian untuk menentukan dia status nutrisinya undernutrition ya atau wasting ya, kita bisa menggunakan indikator berat badan per tinggi badan. Nah, kenapa ini sangat penting ya? Severe undernutrition can weaken the immune system ya. Jadi ini dapat mengganggu sistem imun. Kemudian delay growth and development, menghambat pertumbuhan dan perkembangan, and increase the risk of infection and chronic disease, dan meningkatkan resiko penyakit infeksi dan kronik. Early detection and proper treatment are essential to save life and help children grow healthy and strong. And next, micronutrition deficiency. Several essential mineral and vitamin that can be deficiency include iron, iodine, vitamin A, D, magnesium, and zinc. This deficiency can negatively impact a child's health and growth and development. For example, prolonged iron deficiency in children aged 0 until 2 years can cause anemia, impaired immune system function, and disruption of brain development. In addition, deficiency of several micronutrients such as zinc, potassium, magnesium can lead to stunting. Okay. And next, overweight, obesity ya in children ya, obesitas pada anak. Overweight is chronic condition caused by the consumption of high calorie food ya. Jadi penyebabnya karena tingginya konsumsi kalori ya, dan kurangnya aktivitas fisik ya. Ini dapat menyebabkan overweight ataupun obesitas. Nah, you can one healthy eating pattern, two physical activity, and three behavior modification with parental support. Okay, the closing together we can build a healthier generation ya. Jadi bersama kita bisa membangun generasi yang sehat. Tentunya dengan generasi yang sehat kita menciptakan yang unggul. Okay, thank you for your attention. I would now like to return the moderator. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Keren. In Zoom?
Ya, join.
Baik, bersama dua narasumber yang luar biasa kita buka termin pertanyaan. Barangkali untuk termin yang pertama masing-masing satu penanya dulu ya. Jadi ke Bu Nurjana satu penanya, kemudian ke Pak Zulkifli juga satu penanya. Silahkan, di sini ada Bu Cakra ya. Bu Cakra raise hand, kemudian satu lagi tadi ya Bu Cakra dulu, silahkan Bu.
Okay, I wanna ask for
Oke, biar tidak lupa.
Oke, next question ya. Jadi peran kita sebagai bidan ya. Jadi tentunya bukan hanya bidan yang berperan di sini ya. Nursing, perawat juga ya. Kolaborasi antar interprofesional ini sangat penting dalam mewujudkan generasi yang cemerlang melalui 1000 hari pertama kehidupan ya. Jadi sebagai bidan tentunya kita punya peran untuk bagaimana supaya generasi kita di 1000 hari pertama kehidupan ini betul-betul disiapkan semaksimal mungkin. Baik nutrisinya, simulasinya, ini sangat penting ya. Jadi midwife play a vital role in ensuring to success of the first 2000 days ya. Of life because they provide continuous care from preconception period, pregnancy, childbirth, postpartum period, and early childhood ya. Jadi kita punya peran ini secara berkesinambungan ya, mulai dari menyiapkan kehamilannya, kemudian bagaimana mengawal kehamilannya, kemudian persalinan yang sehat, ibu melalui masa nifas tanpa penyulit apapun, dan tentunya untuk pemantauan pertumbuhan dan perkembangan bayinya setelah lahir itu juga sangat penting ya. Jadi tugas kita di situ ya. Jadi tugas kita itu secara komprehensif dan berkesinambungan ya. Nah, apa yang penting kita lakukan di sini ya, tentunya kita mengawal bagaimana maternal nutritionnya ya, bagaimana meningkatkan kunjungan antenatal care-nya ya, sesuai dengan program ya, yang minimal dilakukan kunjungan itu 6 time ya, 6 kali kunjungan ya. Jadi 6 kali kunjungan, kemudian bagaimana kita mensupport pemberian ASI ya sesuai dengan rekomendasi WHO, ada sesuai dengan rekomendasi WHO mulai dari inisiasi menyusu dini, kemudian pemberian ASI eksklusif ya, kemudian pemberian MPASI dan melanjutkan pemberian ASI sampai bayi usia 4 tahun ya. Jadi 4 rekomendasi WHO ini yang harus kita jalankan untuk memenuhi di 1000 hari pertama kehidupan untuk menciptakan generasi yang berkualitas sebagai pondasi untuk tumbuh kembang bayi. Ya, tentunya ini bukan hanya menjadi tugas bidan ya, kita perlu melibatkan keluarga, kita perlu kerjasama dengan interprofesional ya. Jadi mungkin itu Ibu Cakra atas jawaban yang diberikan atas pertanyaannya.
Thank you for your insightful explanation. I really appreciate your perspective.
Okay, you're welcome.
Terima kasih Ibu Cakrawati dan juga Ibu Nurjana. Ya. Melanjutkan pertanyaan berikutnya tadi sepertinya ada yang raise hand ya. Ini kepada Pak Zulkifli tentunya. Buka satu penanya. Bapak-bapak expert juga ini di kebidanan ya. Oke, ada Mr. Indirwan Hasanuddin. Silakan. Ini saya panggil Bapak atau ini paling aman ya?
Oke, Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Excuse me, I would like to address the question to Nurse Zulkifli. My name is Indirwan. I am lecturer in Nurse Professional Program. Thank you for your highly insightful presentation. My question is, what is your view on the role of application, particularly in healthcare at present? For instance, 3R robots been critics to replace nursing. Do you consider this a trick to the nursing profession in the future? Thank you. Pertanyaan saya begini, Pak Sul, menurut Anda saat ini bagaimanakah perang aplikasi khususnya untuk pelayanan kesehatan? Nah, salah satu contoh seperti kita ketahui adanya diciptakan salah satu robot yang menjadi pengganti dari tugas sebagai perawat. Nah, apakah menurut Anda apakah ini ada ancaman khususnya profesi keperawatan ke depannya? Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Pertanyaan yang luar biasa. Silakan langsung ditanggapi Pak Zulkifli.
Yeah, thank you for question. Ya, kalau saya tuh menanggapi seperti ini, Mas Indirwan ya. Ya, jadi untuk peran teknologi di dalam pemberian layanan di keperawatan ya, umumnya di kesehatan, bahwa kita perlu memahami bahwa teknologi itu bukan pengganti diri kita sebagai tenaga profesional, tetapi itu tools untuk membantu kita bagaimana meringankan pekerjaan kita dalam sehari-hari. Ya, misalnya sebagai contoh kecil, ya kalau kita masih ingat ya, kita memberikan edukasi kepada masyarakat, masih menggunakan leaflet yang menghadirkan masyarakat langsung ya, secara tatap muka. Ya, tetapi dengan adanya teknologi dalam perkembangan zaman yang sekarang ini, untuk materi dalam yang kita mau sampaikan, ya, materi edukasi yang kita mau sampaikan kepada masyarakat, ya itu tentunya peran kita sebagai tenaga kesehatan ya, ide atau materi yang disampaikan itu disampaikan dalam bentuk elektronik ya, misalnya dalam beberapa aplikasi yang menjadi bantuan yang tadinya kita menghadirkan diri secara langsung ya, tetapi kita sudah diwakili oleh aplikasi yang memperpendek jarak tersebut ya. Tadinya kita memberikan secara langsung yang menghadirkan pasien, kemudian menghadirkan perawatnya. Sekarang edukasi itu ya secara langsung bisa diakses melalui smartphone-nya. Ya, begitupun juga dengan kalau misalnya teknologi robot misalnya, ya peran kita sebagai perawat dengan robot itu apalagi sama dengan apalagi teknologi itu akan membantu kita ya, tetapi tidak menggantikan perannya kita sebagai perawat. Ya, perlu dipahami bahwa tenaga profesional seperti perawat, bidan itu tidak digantikan oleh peran misalnya sebagai robot ya. Ya, karena kita adalah tenaga profesional ya, tentunya memiliki sudah dibekali dengan pengetahuan dan apalagi namanya profesionalitas ya, untuk membantu pasien dalam apalagi namanya menyembuhkan penyakitnya atau tidak tertular penyakit ya, seperti itu mungkin.
Ya, very nice. Bagaimana Bapak?
Thank you for the answer. It's very helpful. Thank you, Mr. Zulkifli Nurdin.
Oke, terima kasih juga Pak Indirwan sudah memberikan question yang luar biasa. Karena waktunya masih ada berapa menit ya? 15 menit tapi tidak kita habiskan ya, semoga. Jadi kita buka lagi two participants to give a questions for Ibu Nurjana and also Pak Zulkifli. Hospital yang bekerja di rumah sakit, berbagi pengalaman juga dipersilahkan ya. Ya. Kira-kira bagaimana? Apakah masih dibuka termin pertanyaan lagi? Ada lagi yang bertanya? Kita buka 2 penanya. Suara saya aman, Bu Mariam? Kayaknya di saya unstable ya. Cek.
Ya, aman,
Halo?
Bu. Aman, Bu, aman, Bu.
Aman. Ya.
Aman ya? Sempat keluar saya. Berarti sepertinya seluruh audiens, sehingga kita tutup ya. Kita berikan applause sekali lagi untuk Mr. Zulkifli dan juga Ibu Nurjana ya, luar biasa. I'd like to thank you very much for all the speakers and very interesting topic to discuss. Ya, tapi bagaimana lagi ya, waktunya kita sudah habis, menunjukkan kurang dari pukul 2. And I think we already 4 speakers here, and we know that we are hand in hand to work in this and how to solve the problem, especially in transforming and enhancing rural community nursing and midwifery care in order to achieve global health equity. Thank you very much for Professor Dr. Farida, Dr. Marina, Mr. Zulkifli Nurdin, and Bidan Nurjana for joining with us in the Zoom. And we appreciate very much. And for all the audience, thank you so much for being wonderful participants during this webinar international sessions. Hopefully to see you again in the next webinar. As a moderator, I apologize for any mistakes. Akhirul kalam, Assalamualaikum warahmatullahi wabarakatuh, and good afternoon. I return it to the last speaker of
Thank you, Tris.
Thank you, Miss. Apaan sih?
Welcome.
Izin Bapak Ibu, untuk postus di pukul 13.50 ya.
PT Prima Medicina Hanacaraka terdepan dalam melatih tenaga kesehatan untuk membangun masa depan Indonesia yang lebih sehat. Selamat datang di PT Prima Medicina Hanacaraka, lembaga pelatihan kesehatan terkemuka yang berkomitmen untuk mencetak tenaga kesehatan profesional yang siap menjawab tantangan di masa depan. Sejak awal didirikan, kami telah berkontribusi dalam meningkatkan kualitas layanan kesehatan melalui pendidikan dan pelatihan yang berkualitas tinggi. Kami percaya bahwa masa depan kesehatan bangsa terletak pada tenaga kesehatan yang terampil dan kompeten. Oleh karena itu, misi kami adalah menyediakan pelatihan yang inovatif, berbasis praktik, dan sesuai dengan standar nasional, untuk memberdayakan para profesional kesehatan dalam memberikan layanan terbaik kepada masyarakat.
Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Halifah, Direktur PT Prima Medicina Hanacaraka. Hanacaraka Training Center Indonesia adalah salah satu anak usaha dari PT Prima Medicina dalam bidang pelatihan dan peningkatan kompetensi SDM kesehatan yang telah terakreditasi tahun 2023 B oleh Kementerian Kesehatan dan telah terakreditasi A tahun 2024 oleh Kementerian Kesehatan dan tahun 2025 telah terverifikasi oleh Kementerian Tenaga Kerja. Alumni Hanacaraka telah menyebar di seluruh Indonesia, adalah sekitar 11.000 peserta yang menyebar seluruh Indonesia, dan lembaga institusi yang telah kerjasama dengan Hanacaraka Training Center Indonesia sekitar 70 lebih lembaga pemerintah maupun swasta, rumah sakit, puskesmas, klinik, maupun lembaga pendidikan. Komitmen kami menghadirkan layanan terbaik melalui keunggulan yang menjadi nilai tambah bagi setiap peserta dan mitra, trainer profesional, metode interaktif dan aplikatif. Hanacaraka Training Center Indonesia punya layanan Hanacaraka Care dan jejaring kerjasama, di mana Hanacaraka Care adalah alur pendampingan peserta secara menyeluruh dari awal kegiatan pelatihan hingga pasca pelatihan untuk memastikan kompetensi terrealisasi dan berdampak di tempat kerja. Jejaring kerjasama kami dengan rumah sakit dan pasienkes, dinas kesehatan, perguruan tinggi, organisasi profesi, perusahaan BUMN, BUMD, dan perusahaan maupun instansi lainnya. Komitmen kami hari ini untuk kesehatan Indonesia dan untuk peningkatan kompetensi tenaga kerja yang lebih baik untuk esok. Hanacaraka Training Center Indonesia akan terus berinovasi, memperluas kolaborasi, dan memberikan layanan pelatihan terbaik untuk mencetak tenaga kerja dan tenaga kesehatan yang kompeten, profesional, dan berdaya saing global, sehingga layanan yang diberikan layanan. Misi kami adalah menjadi potensi tenaga kesehatan dan tenaga kerja relevan untuk meningkatkan kompetensi dan mutu layanan kesehatan dan tenaga kerja. Nilai kami integritas, kompeten, inovatif, kolaboratif, berorientasi pada mutu.
Marilah bergabung bersama Hanacaraka Training Center Indonesia untuk meningkatkan knowledge dan skill SDM kesehatan dalam meningkatkan kesehatan masyarakat dan menyukseskan Indonesia maju dan sehat.
Baik, kita tutup kegiatan pada hari ini. Semoga apa yang sudah disampaikan oleh narasumber bermanfaat bagi Bapak Ibu semua. Kurang lebihnya kami mohon maaf apabila ada salah kata maupun perbuatan. Mohon maaf yang sebesar-besarnya. Kami tutup pada kesempatan kali ini. Wassalamualaikum warahmatullahi wabarakatuh. Selamat siang Bapak Ibu.
Waalaikumsalam warahmatullahi wabarakatuh. Selamat siang, Bu.
Assalamualaikum.
Bagi Bapak Ibu yang terkendala terkait dengan akun Satu Sehatnya untuk dapat bisa konfirmasi di dalam grup agar kami nanti dapat bisa merespon kendala Bapak Ibu semua. Terima kasih, selamat siang.